Midlife Conference. Midlife Conference Workshop Module 2. This workshop is about Cosmesis in midlife, which is an absolutely fascinating topic for discussion. The workshop will be inaugurated by Dr. Shobana Mohandas little later. We will start with introduction of the first session.
Yeah, thank you.
I am Dr. Padma, obstetrician gynecologist and the current treasurer of Chennai Menopause Society. I'll be joined as coordinator with Dr. Geeta Raja. She'll be joining soon. And
skip this. Danadu Sambat.
Dr. Sampath. Yes. Dr. Sampath Kumari is coordinating this session. She is currently Chief and HOD of Muthukumaran Medical College and current Vice President of FOGSI. She has so many laurels in her hat, and she was a chairperson of FOGSI Adolescent Health Committee, and she has written plenty of chapters in FOGSI textbooks and won Karamveer Chakra Award. And Madam, are you ready?
Madam will be ready next few minutes.
Deepa, put the Deepa.
Yes. Dr. Deepa Tangamani will be joining us. And she is a current consultant in Apollo First Med Hospitals and joint secretary of the Chennai Menopause Society at present. Deepa is also a very talented gynecologist with so many awards and has presented many papers and posters in international conferences. Deepa, can you take over? Thank you.
Thanks, Batma. At the outset, I thanks the organizing team for giving me this chance. We'll just go to the session first. I may invite Dr. Yashwant Kumar Venkatraman to speak on cosmetic dentistry in restoring the youthful experience. He is a senior consultant dentist and orthodontist, is specialist in cosmetic and laser dentistry, is a founder and chief consultant Yas Dental. He is also a medical director and Parazu Dental Group and founder and chief mentor of Parazu Academy of Continuing Education, and he got a Best Teacher Award from the Dr. MGR University. Over to Dr. Yashwant Kumar for a fantastic talk on cosmetic dentistry. Thank you. Doctor, you can unmute yourself, Dr. Yashwant Kumar, sir. You're unmute and you can share your screen.
Dr. Yashwant.
Dr. Yashwant.
Ma'am, sir can unmute.
Dr. Yashwant, can you unmute yourself?
Dr. Yashwant, can you?
I think he's not able to hear. Dr. Yashwant?
Hello? Yeah, you can share the screen.
Chitram, Dr. Yashwant is there?
Dr. Yashwant.
I think he lost his connection. I think, yeah.
Dr.
His video
Mala,
is coming.
Dr. Mala has his number.
I think, madam, he's having some issues with his internet.
Okay.
Who's the next speaker?
I don't think so, Mala. Next speakers have joined yet. Dr. Annie, Dr. Vaishali, and Dr. Senthilvel.
I have joined. I'm Dr. Vaishali.
Oh,
yes.
then.
Can you start your Can I
I can.
introduce Dr. Vaishali? So shall we move on to Dr. Vaishali's talk? Batma, can I move to Dr. Vaishali's talk?
Yeah,
Can I invite Dr. Yeah, Dr. Vaishali is a breast surgeon. She got her oncoplastic MCS breast surgery from the University of East Anglia, UK. Additional training in oncoplastic breast surgery at Cardiff School of Medicine, Wales, UK, and passionate about research in the field of breast cancer. She is going to talk about breast reconstruction after mastectomy. And over to Dr. Vaishali.
Thank you. I hope my screen is visible and I'm audible.
Yes.
Yes, yes.
Yes,
you're
ma'am.
clear.
Okay. So at the very outset, I would like to thank Dr. Hepzibah and the organizing team of this conference for giving me this opportunity. I'm going to, in next couple of minutes, I'm going to talk about breast reconstruction after mastectomy. So we all know that a woman's breast symbolizes motherhood, feminine form, and beauty. However, unfortunately, it is also a site for diseases like cancer.
Okay, so what do we do then?
What I'm going to cover in the next couple of minutes is a brief journey of breast reconstruction. So what are the options for a woman who has undergone mastectomy? What is the selection criteria, the timing of breast reconstruction, and whom we cannot do reconstruction, then follow-up and some special concerns. So a little bit about the brief history of breast reconstruction. We all know that for many, many years before the 18th and 19th century, the breast cancer treatment was considered to be a wasteful thing, or breast cancer was considered with a nihilistic approach. However, in the 1890, that is before the turn of 19th century, Professor William Behelstead actually described a very systematic procedure called as radical mastectomy, which was adopted wholeheartedly by the surgeons, and it continued to reign for next 100 years till 1970s, when modified radical mastectomy was described, and it was considered to be a gold standard for treatment of breast cancer. Later on, in the late 20th century, it was proved by many randomized trials that breast conservation surgery is also an oncologically safe procedure in select few patients. And later on, we also realized that patients who have large tumors, as well as patients who have tumors which are located in some unfavorable locations, also can be managed with breast conservation surgery by use of oncoplastic breast conservation techniques. However, there are certain patients who are likely to require mastectomy, and these patients are patients who have undergone surgery for breast cancer, as well as those who are at risk of developing breast cancer. So a little bit about the breast reconstruction timeline. The first ever reported breast reconstruction was in the year 1895, when Vincent Journey used a lipoma in the back of a patient for using to reconstruct her breasts. Later on, then some more surgeons used various techniques like use of pectoral muscles. Then somebody used LD, Latissimus dorsi flap. Then some people tried using half of the contralateral breast and all that. Later on, the technique of breast reconstruction got refined, and in the year 1971, Siderman and Guthrie performed first immediate breast reconstruction with use of silicone implant. And in the year 1982, tissue expander was first used after mastectomy. And this Baker is a very actually pioneering, he has done a pioneering work in breast reconstruction, and Baker's prostheses are very commonly and very widely used worldwide. And in the year 1984, the first dual implant, that is inner expander and outer silicone implant, was actually pioneered by Baker. So who are the candidates for breast reconstruction? You know this famous Hollywood actress Angelina Jolie. So I'm going to talk a little bit about that indication as well. So patients who have to undergo mastectomy for breast cancer treatment, and those women who have a high lifetime risk, that is more than 25% risk of development of breast cancer, they are actually advised risk-reducing mastectomies, the similar to the surgeries which Angelina Jolie has undergone, because she had a BRCA mutation which she had inherited from her mother, and she was at a risk of developing breast cancer. So she underwent double mastectomy and reconstruction at the same time. So those patients who harbor BRCA mutation or other genetic mutations which put them at high risk for development of breast cancer are advised risk reducing mastectomy, and they can be advised to undergo breast reconstruction. So what are the reconstructions options currently available? The lady can undergo immediate reconstruction after her breast cancer surgery, or delayed reconstruction after the completion of entire breast cancer treatment. Patients who are candidates for risk reducing mastectomies ideally should undergo immediate reconstruction. And then there is another option of doing immediate delayed reconstruction. That means that a person who is actually undergoing surgery for breast cancer can wait for maybe 8 or 10 days to get her final pathology report and to ascertain whether she is likely to require radiotherapy or not. Because we know that patients who undergo reconstruction and then they have to, if they have to be given radiotherapy, then the cosmetic result after reconstruction are inferior. So patients requiring radiation are advised to wait for some time before the reconstruction can be carried out. And if the lady is not likely to require radiotherapy, then after maybe 8 or 10 days after the initial mastectomy, she can undergo reconstruction. So it can be performed in a single stage. That means by using either a direct implant or by using autologous flaps, or it can be used done in 2 stages, like expander is used first and then it is replaced by an implant later. And the various techniques of doing breast reconstruction is either purely implant based or purely autologous tissue based, or implant plus flap, autologous flap hybrid method. So what all procedures come into the purview of breast reconstruction? These are reconstruction surgery per se, yes. And then these patients need to undergo some corrective procedures to achieve complete symmetry. And sometimes they also need to undergo fat grafting for minimizing the cosmetic defects which are produced as a result of reconstruction. Then women who have to lose their nipple areola complex also need to undergo reconstruction of nipple areola complex. And then, because if the patient is undergoing unilateral breast reconstruction, then it has to be matched with the other breast. And sometimes the other breast can be, will probably need to be reduced or will need to be augmented to match with the reconstructed breast. So what are the goals of reconstruction? The goals are to restore feminine form after breast cancer surgery or after risk reducing mastectomy, and to achieve cosmetically pleasing and symmetrical breasts to match the size, shape, contour, and nipple areola complex position. And as a result, the final ultimate goal is to improve the psychological, physical, and sexual well-being of the patient. And the important goal is to do all these reconstruction procedures at minimal morbidity and for giving long-lasting results. So what usually the patients have certain expectations from breast reconstructions. These are that the patient should not be should not need external prosthesis for giving that contour. Then the patient should have a perfectly symmetrical breast. Then there should be less musculoskeletal problems. The patient should have restored body image, and the reconstructed breast should have a good real breast-like feeling, and that should help her improve her self-esteem and sexuality. And as a result of breast reconstruction, the patient expects that she should get her pre-cancer wholesome body image restored. However, unfortunately, what God has made, we as surgeons cannot make that perfectly, but to a large extent, we can match these patients' expectations. So selection criteria, there are certain factors which are to be considered, like patient's body habitus, then whether the patient has previously undergone any breast cancer surgery or any breast surgery, and whether there are any scars on the breast or not. whether the patient has undergone radiotherapy in the past, what are her comorbid conditions, does she have uncontrolled diabetes, is she a smoker, then what are the patient's desires, what does she desire, whether she wants large breasts or moderate sized breasts, what should be the color of the, what should be the texture of the breast, what is her occupation. If the patient is indulging into intense labor activities, then probably she should reconsider whether she needs to undergo reconstruction or not. Then patient's hobbies. Some women are avid athletes or they are trekkers. Then usually breast reconstruction may be difficult in these patients. Then disease factors based on what is the loss of volume in a patient who has undergone mastectomy, whether that patient is likely to require radiotherapy or not, and whether she is going to require intense surveillance for her breast cancer, then probably the patient should be asked to go for a delayed reconstruction, so that at least 2 to 3 years should be passed after her breast cancer treatment, so that we can safely perform her breast reconstruction. And of course, cost and availability of resources and expertise has to be considered in a significant way before reconstruction can be offered. So at the end of this counseling for breast reconstruction, the patient should be really motivated to undergo reconstruction, because she should be counseled regarding some minor corrective procedures which probably might be needed, especially if she is undergoing implant related reconstruction. Then what should be the best timing? Obviously, whatever the patient desires. However, if the patient is likely to require adjuvant radiation, then definitely the reconstruction should be deferred at a later date. And of course, as I mentioned, disease stage and biological profile of the disease is critically important. So what are the advantages of doing immediate reconstruction? Patients actually wake up after surgery with a breast, and there are better results like color match, sensation, and aesthetic results are much better in immediate reconstruction. And it can be carried out at a lower cost because both the surgeries can be carried out under one anesthesia. However, patients who are undergoing delayed reconstruction usually tend to have less optimal results, and they have to undergo 2 procedures, one for the primary breast cancer surgery and later on for reconstruction. Probably might lead to more complications and definitely lead to psychological anxiety. And immediate delayed reconstruction can be carried out 10 days to 2 weeks from the mastectomy. So these are the results. On the right hand side, you can see that this was a delayed reconstruction, and you can see on the left hand side, this is immediately done. So you can see the cosmetic results between the two. Immediate is showing much better cosmetic result compared to the delayed one. Let us talk a little bit about autologous reconstruction. That means that the reconstruction is carried out using patient's own tissue. So what are the tissues which are used? So biocutaneous or lipofasciocutaneous flaps are used. So these flaps can be pedicled or free flaps, and the flaps can be obtained or harvested from abdomen, back, thigh, or buttocks. So pedicle flaps are the flaps which are actually situated close to the breast, that means on the chest wall. Usually LD flap and tram flap are used. That means that the blood vessel of the flap is not detached completely from the donor area, but the flap is rotated without detaching the blood vessels of the flap. And a microvascular free flap can be obtained from a distant donor area, and the blood vessels are detached from the donor area, and then they are re-anastomosed with the recipient vessels. So the commonest example is deep inferior epigastric perforator based breast reconstruction. I'm going to show a little bit about the pictures. This is the tram flap. It was in vogue around 20 years ago, but nowadays it has been completely replaced by DAP flap, because here you need to sacrifice the rectus muscle and can lead to hernia formation. This is the Latissimus dorsi flap, which is used for breast reconstruction, but LD flap for reconstruction can be used only for patients who have small breasts, that is up to 32B size cup. Then DAP flap, this is the versatile flap, and it is very, very commonly used for breast reconstruction in current times. And it does not need to harvest the muscle. So the complications which are there in tram flap can be minimized. Then this is the superior gluteal artery perforator base flap. Flap can be harvested from the superior as well as inferior gluteal artery perforator based territory. And this is from the thigh, that is transverse upper gracilis flap, which can be harvested from the superomedial aspect of the thigh. So tram flap is used when the patients actually need excess unilateral reconstruction and they have excess lower abdominal panniculus. LD flap is used for thin patients who have inadequate abdominal fat. DF flap actually is preferred these days and especially useful for patients who have bilateral reconstruction. S-gap and tug flap are actually used for very unique cases when they have abdominal scars, those who have undergone previous abdominal surgeries, or if they do not have any adequate fat in the lower abdomen. Then I told you about pedicle flap and free flap. In pedicle flap, there is a potential loss of function because the muscle needs to be sacrificed. And in free flap, although the muscle is actually spared, but it requires a long operative duration and it is a complex surgery. So what are the pros and cons of autologous breast reconstruction? After the surgery, usually the patients get soft and more natural feel of breasts. Usually there is no need of multiple procedures. However, the procedure is technically demanding and it has a long lasting operative duration. And there is obviously donor side morbidity, there are long scars, and there is obviously a potential complication related to flap loss. Then move on to implant breast reconstruction. It is a less invasive surgical procedure and doesn't have any distant donor site morbidity. But in India, there is a lack of availability of variety of implants to choose from. And then there are various techniques of doing either a single stage or two-stage procedure. And the implant can be placed either just under the skin, that is prepectoral, or beneath the pectoralis major muscle, that is subpectoral. And in case, especially if the patient is undergoing this implant-based reconstruction, then they need some support at the lower pole to prevent the implant from migrating downwards. So these are the pictures of pre and subpectoral implant placement. There are various types of implants which are available in the market. So they can be anatomical, that is teardrop shape, or they can be round. They can be textured or they can be nano textured, and based on the patient's breast size, the contralateral breast size, then the low profile or high profile or extra high profile implants can be used. A little bit about the stage procedure. Usually after the mastectomy, a tissue expander is placed and the breast mound is created using a tissue expander, and the saline is actually serially introduced into the tissue expander at regular intervals. And later on, maybe after a couple of weeks or 2 to 3 months, once the adequate expansion of the skin is achieved, then the expander is replaced with an implant. And later on, for achieving symmetry, some minor procedures may have to be done. And nipple and areola reconstruction can be done at later date, and areola tattooing can also be done. So these are the steps of two-stage implant based reconstruction. This is the lady who has undergone mastectomy. Then implants were introduced. Expander was introduced and gradually it was inflated, and both the expanders were later on replaced by a permanent implant. As I said that at regular intervals, the expander needs to be inflated with saline, and occasionally the expander can also be left behind for many years before it is actually replaced by implant. So many times women do not come back for replacement with implant. They still go on living with an expander. Sometimes it can happen. And I told you about this. And then I said that sometimes we need to put some support to the implant lower down. So either a tram flap or a LD flap also needs to be used for giving support to the lower pole of the implant. This is the single stage implant reconstruction, wherein this is the this is called as acellular dermal matrix that is available in the Western countries, not available in India. This is actually used for supporting the implant lower down, and sometimes the implant can be completely covered in the acellular dermal matrix before it is put under the skin. What are the disadvantages of implants? It can lead to infection, hematoma, seroma formation, and occasionally delayed healing, especially patients who are diabetic. Then there can be a potential complication of implant leak, or the implant can rupture. And majority of the implants have a notorious tendency to develop capsular contracture and can lead to very hard feel of the reconstructed breast. Implants can migrate. As you can see here, the implant has migrated. Then the rippling, the implant can show some wrinkles, and that rippling can be visible from outside. Then there could be extrusion of the implant, then excessive scar formation, asymmetry, and occasionally the patient can have dissatisfaction with the cosmetic result of the procedure. So who are the ideal candidates for implant based and autologous? Patients who have thin to average build, who do not have any excessive fat in the lower abdomen or in the back, and who require a shorter duration of surgery so that they can get back to work quickly. These patients can go very well ahead with implant-based reconstruction. And for autologous flap-based reconstruction, the ideal candidate is those who have excessive fat in the lower abdomen or back, and those who do not mind scarring or an additional scar in the lower abdomen or on the back, and those who are not obese can be actually subjected to autologous flap-based reconstruction. A little bit about nipple reconstruction. It is done at a later date. In case if the patient has to undergo removal of the nipple areola complex, it can be done in staged manner. And the minor contourial deformities can be corrected by injecting patient's own fat at subsequent times, so that the symmetry can be maintained and patient can get a beautiful cosmetically symmetrical breast results. Patients who have undergone reconstruction can undergo regular follow-up. Patients who have had breast cancer surgery need to undergo regular follow-up as per protocol. And patients who have undergone risk-reducing mastectomy and reconstruction, they have to see the patients annually. And reconstructed breast can be subjected to mammography, ultrasound, and MRI as well. So there is no worry about if they have developed cancer, then what should happen. It can be done in those patients also. So to conclude, I would like to say that breast cancer treatment has to be approached with a holistic manner. Breast reconstruction improves quality of life of breast cancer patients, and as a part of breast cancer treatment, breast surgeons must explain the options of breast reconstruction to all women undergoing mastectomy, whether it is immediate or delayed. And the choice of the procedures, whether implant based or autologous based, is based on multiple factors. I mentioned them previously. And although in the current times, the insurance, medical insurance does not cover all the reconstructive procedures, but we as medical professionals, we must push the medical insurance companies so that the patients who undergo mastectomy or risk-reducing mastectomy as a part of their breast cancer journey should not be denied medical insurance for this reconstruction, because this is a part and parcel of their well-being. So I would like to thank you for your patient hearing and would welcome any questions if you have. Thank you.
Thank you, Dr. Vaishali. It's a wonderful talk. I can't say any questions in the chat box. I just want to ask one question. So in India, because the availability of various implant is not much available, varieties of implant is not much available in as per your talk. So what will you advise? How will you choose your patient for the reconstruction? It's like only you do go for implants. Hello.
Yeah, so I was not allowed to unmute. I'm very sorry.
Okay.
I'm very sorry. Deepa, can you just quickly repeat the question? I was worried about. Yeah.
The varieties of implants is not available in India.
Yeah. Right. Correct.
So in your practice, how will you do this select your reconstructive patients?
So we generally do, the reconstruction using the available implants. There are two companies which are currently providing. So one is a silicone implant and one is a mixed saline and silicone implant. So we don't have really a big choice for that. So whatever choice we have, we show those implants to the patient, and then based on her choice, we go ahead. And majority of the patients do require some kind of, flap cover underneath, so that the implant gets really nicely seated in the either in the behind the pectoralis major muscle or just beneath the skin. So we really do not have the choice. And we explained to the patient about the pros and cons of autologous reconstruction. So I would say that 50% of the patients go for autologous reconstruction, 50% patients do go for implant-based reconstruction.
Thank you so much. Dr. Padma is also available. Dr. Shobna Mohandas madam is also available. So are you going with the welcome address? Doctor, shall we move on to the next speaker? Shall we?
No.
Dr. Yashwant,
Deepa.
Dr. Yashwant.
Dr. Shobna has come.
Then we'll welcome madam.
Madam, yes, madam.
Share madam's CV.
Yeah, good afternoon, Dr. Shobna.
Hi, Mala.
Hey, how are you?
Fine.
Good to see you.
Yeah, good to see you. You are talking on your lasers, I think.
Yeah, RF, both RF and laser.
Okay. You bought it long back, no?
Yeah, almost. Now it's going to be like 4 years.
Yeah. When you're not on your laparoscope, you're on your laser, no?
Oh my God, laparoscopy. Oh my God, that is my passion. This is additional, that's it.
Good afternoon, madam.
Good afternoon, Dr. Padma.
We now welcome you to the Changes Not Challenges Midlife Conference, and we would like you to inaugurate the workshop and please say a few words about the workshop.
Good afternoon, ladies and gentlemen. I thank Dr. Hepzibah Kiribanamani for inviting me for this session to inaugurate it as President-elect of Indian Menopause Society. And I'm very glad that she is a bee, and I don't know how much energy she has. She keeps on conducting programs and she goes on calling up people, and this meeting is something which is the need of the hour. After I thought, what is there to talk about in breast reconstruction? And now I've heard so many things in breast reconstruction. So we think only laparoscopy is there to listen to, or menopause is there to listen to. And somehow bringing out things which are there beyond us and getting them to a platform and giving it into people is the need of the hour. And there is nobody else other than Dr. Hepzibah Kiribanamani with a rose in her head who can do this. And I thank you for conducting this, collecting so many eminent faculties here. And I hereby say that this session is inaugurated. And I wish the session all the best, and it's going so beautifully. And I'm very sure that on a Saturday afternoon also, there are so many people attending it. Sampath Kumari is there. I don't know whether she's there behind it, but I can see her also there. Then my friend Mala Raj is there. So many others are there. And I'm very sure this session will go beautifully. And I hope Hepzibah Kiribanamani comes higher and higher in IMS with so many activities. And wish you all the best.
Thank you so much, madam.
Dr. Shobna, good afternoon. I'm here only, but I am with my grandchild, so I have closed my video. That's all.
Yeah, I thought.
Okay.
Thank you.
Next.
Dr. Yashwant, can you able to hear?
Yeah, I can.
Deepa,
Can share your...
Deepa, welcome address by Dr. Hepsi madam.
Okay.
So
sorry, yeah. Hepsi madam, invite.
Yes, yeah. Deepa, we'll
Yes,
cut short. Yeah, it's indeed a great pleasure for me on behalf of Chennai Menopause Society to welcome Dr. Shobna Mohandas, President-elect, who has passion for midlife and mature women's health. She's always there. I know her for the past nearly 5 years. She's always keen on all these programs. And welcome you, madam. It's my privilege to welcome the faculty, Dr. Vaishali, who has done a wonderful lecture now, and Dr. Yashwant, eminent faculty, Sendal Vail, Ragini Natasha Sejal, and I have immense pleasure in welcoming our Reed Allison, who is a urogynecologist, pelvic surgeon, and aesthetic cosmetic vaginal surgery person. I think I'm sure at the end, we know how to reconstruct, how to have an aesthetic genital surgeries. We can learn so many things from this workshop so that the midlife women's beauty can be preserved or restored or enhanced. Their physical appearance definitely is going to improve. Thank you. And I once again welcome each one of you.
Thank you. Thank you so much, madam. Deepa?
Yeah.
Can you
Next,
take
Dr. Yashwant, you can share your screen now. Dr. Yashwant is going to talk about on cosmetic dentistry and restoring a youthful experience. Over to you, sir.
Yeah, are you able to see?
Sir,
Yes.
sir, shall I share the screen because
Yeah.
it is in mobile mode?
Yeah,
So I
please,
will share the screen, sir.
please.
Is my screen seen, sir?
Yes, yes, yes.
Yeah.
Yes, Mr.
Yes.
Madam President of the Indian Menopause Society, Dr. Hepzibah, Dr. Mala, and the other gynecologists, eminent gynecologists, thank you for asking me to speak today about cosmetic dentistry. It gives me great privilege to speak to such eminent people, and I'm happy that Dr. Mala decided that dentistry and especially cosmetic dentistry has to be part of this. So thank you, Dr. Mala, for deciding to put me on board. Can we go to the next slide, please? Yeah. I'm sorry about the goof up which happened about a couple of minutes ago. I had a problem with my computer and I was not able to share the screen. So I had to give it to one of your colleagues to do it. So he's sharing the screen on my behalf. Thank you so much. So today I'm going to speak about cosmetic dentistry. But before we speak about the subject, I would also want to remind you that you are all very senior gynecologists and you see very, very complicated cases. So it's very common for you to ignore or, not come across major complaints with women during pregnancy or puberty or menopause complaining about their teeth. It's very, very rare. And I'm sure you don't think of it too much because there are other serious issues. So I would like to touch upon that subject a little bit before we go ahead to cosmetic dentistry. As you know, the changing hormonal levels during the menstrual cycle, pregnancy, and menopause can affect the gums. Basically, it affects the gums. It causes a problem called periodontitis. And the periodontitis is nothing but gum disease. And there are different stages of periodontitis, mild, moderate, and severe. And generally for younger teens and women who are pregnant, we see the milder form of periodontitis. But for many women who are about to reach menopause or cross menopause, we find that they are already in the mid-level or in the severe stage of periodontitis. So this is a very important point that I would request all of you to remember while treating your patients. Consider the dental condition as well. And next slide, please. Yeah, so the, of course, regular mouthwash, brushing, flossing, and things like that does improve the general health. But if there is a specific requirement, which many pregnant women and especially post-menopause women have, this has to be treated at the dentist level, not at home care. Many of them do a lot of home care, and then when they come to us, it is at the level of moderate or severe periodontitis. So it's important to identify, and I think you will play a major role in identifying, because they generally don't come directly to the dentist for such issues. Next slide, please. So in menstruation, again, most of the women, girls who start, get into puberty at their very young age, do not have a great brushing cycle. They do not think too much about flossing. So these are issues which need to be brought up to them. A visit to the dentist, just a visit to the dentist, maybe a cleaning and some oral hygiene instructions for a small child will go a long way in maintaining her teeth till her adulthood. Next, please. So especially during pregnancy, I'm sure you know this, and you've seen a lot of cases of periodontitis and gum disease. Progesterone and estrogen levels go up, and that causes a lot of gum swelling. So a lot of gum swelling. And then teeth start to even get a little mobile because of the loss of periodontal attachment. Periodontal attachment is the attachment between the gum and the tooth, which is lost due to the inflammatory reaction at that point of time, especially during pregnancy. And as you know, we are not allowed to give antibiotics. We are not allowed to take x-rays during pregnancy. So it's a big challenge for us to treat pregnant women. So it is very important when the lady is planning to have a child to have one dental checkup, just to make sure things are okay and things are normal, and get some oral hygiene instructions. Next, please. Yeah. So again, hormonal levels changes here happens. Estrogen deficiency happens, and that causes canker sores in the mouth. It can cause pain due to ulcers. These are very, very common. And dry mouth syndrome, as you know, salivation decreases for postmenopausal women, and this can be exaggerated in certain women and not so much in the others. So this has to be treated at the dentist level, because this can also cause, saliva helps in self-cleansing in the mouth. It's not just brushing and flossing. It's also a major part of the self-cleansing happens because of saliva and clavicular fluid. So this is restricted, it's reduced, and because of which the lady can women develop decay and periodontal disease. So it's very important to treat it at the earliest. And of course, osteoporosis can also affect the jaw, and tooth loss is quite common post-menopause. So this is also to be noted. Thank you. Next one, please. Yeah. So coming to the subject which I'm going to be talking today, when I started 20 years ago as a cosmetic dentist, my aim was to treat younger teens, younger adults, adolescents, adults, and I was not even looking beyond 35, 40 years of age. I was looking at younger people, celebrities who would want to get their teeth whitened, brightened, and laminated. But of late, 60% of my patients are elders who are 60 plus, 55 plus, who have the time right now. They've been busy in their lives and they have had children, they're working, especially women. They've had so many challenges, and now they have the time to take care of their teeth. So when they come to us at this age, some of them, yes, we are able to give them fantastic results without making it very invasive. But in certain cases, there is definitely a lot of work to be done, because the maintenance for the last 20, 30 years would have been really bad. So cosmetic dentistry is no longer just for youngsters or adolescents or teens. It is mainly, like I said, 50, 60% of my patients now are elders, postmenopausal women, men who are retired, who have the time right now. They want to get their teeth fixed and have good food, and a good smile. So this is the kind of population or people coming to us right now for cosmetic work. So there are a couple of options available what we can offer them. So we'll go to the next slide, please. So these are some of the options available from left to right. Teeth whitening. I'm sure all of you know what is teeth whitening. So we clean the teeth, we whiten the teeth, make it slightly brighter. We remove the smear layer and make the teeth look good. It's clean, it looks good. And very rarely there are some side effects of sensitivity, but that's negligible amount, maybe 1 or 2% of the cases. Bonding is a process where we fix broken teeth, especially in the front anterior smile area. Veneers, I will explain in detail inside the slide, but inside the presentation, but this is basically a sheet of ceramic or composite filling material, which is stuck on the front surface, facial surface of the teeth, which will give a better looking appearance and also functionally help people chew and eat well. Aesthetic crowns are when the veneers are not possible, fillings are not possible, then we will have to normally go in for a root canal and then give them crowns. Tooth replacement, of course, you know what is tooth replacement. We'll go to options of tooth replacement in a while. And of course, orthodontics is now very popular, even among elders, even among middle-aged women and elderly women. So next slide, please. So the first is for teeth whitening. This is the simplest of procedures, apart from the cleaning and polishing of teeth. Teeth whitening, we use hydrogen peroxide, a very biocompatible material when it's diluted and used to the proper manner. So we use that material to wash the teeth, apply it on the teeth, and cure it. So once that happens, the smear layer is removed and all the extrinsic stains are removed. Now, this takes about 20 to 30 minutes, doesn't cost too much, and really helps in the first stage. So many of us who would want to get started with some amount of cosmetic work I would recommend that they go in for teeth whitening. And normally this lasts between 6 months to 12 months. It doesn't last forever because your teeth obviously is being used 3-4 times a day and you accumulate a lot of stains. So gradually the shade what we achieve from maybe 5-6 to 0 or 1 to pearl white comes down gradually over a period of 6 to 8 months. So next slide, please. So there are the different types of bleaching available. There's in-office and home bleach as well. Home bleach is mainly for maintenance. It is not used for an active teeth whitening, but for maintenance after the 3rd or 4th month. And if one can maintain it, it may even last up to 2 years. But the regular bleaching with hydrogen peroxide is done in office, that's in the clinic, and is very effective. And there are no side effects of any sort. So it's extremely effective and useful for a starting stage of cosmetic work. Next, please. Yeah, so bonding is another very simple procedure. So this is where we use a composite resin, a filling material, which is tooth colored, which merges with the enamel of the teeth. We have enamel color and dentine colors. So what we do is we generally etch the teeth and apply a bonding agent and apply the cement. We reshape the teeth and make it look very natural. So this is primarily used where patients have broken down teeth, worn down teeth, and which needs minor repairs. Major repairs cannot be done with this. Minor repairs, this is one of the best options. Normally lasts between 3 to 5 years. Next, please. So when we can't do bonding, when the fractures or the shape is too much to repair, then we go in for something called veneers. So veneers are when we have intrinsic stains, it is used. Intrinsic stains are stains which come with birth genetically inside the teeth when you see the stains, which are not removed with tooth whitening. Those stains can be removed with veneers. So veneers, there are 2 types of veneers. One is composite veneers, where we use filling material. And the other one is called ceramic or porcelain veneers. So next, please. Yeah, so these are composite veneers. Composite veneers are made of very thin composite restorations. This is a filling material, and it can be done in a few minutes to a few hours, depending on the number of teeth. Each tooth filling will probably take about 15 minutes, gives a fantastic glossy appearance at the end of the procedure. This is, again, not a permanent solution, normally lasts between 3 to 5 years and looks very good, very fast, very simple, economical. A normal composite veneer probably will cost about 2,000 rupees per tooth. So it's a very economical solution to changing or improving the smile. Next one, please. So ceramic veneers or laminates are a little more permanent solution. They are, again, like I said, made to the surface of the teeth is slightly removed in this particular case, and then some measurements are taken, and a ceramic or porcelain laminate is fabricated and then fixed on the surface of the teeth. Normally it takes about 2 visits. Each visit is about 1.5 hours, depending on the number of teeth, and lasts easily about 10 to 15 years. So the fit and the finish will be perfect. And the biggest advantage of this is it doesn't stain like natural teeth because it's porcelain, and biting, chewing is absolutely normal. And the fit finish, what is fixed on day 1 will remain, and there is no wear and tear. Even the teeth might wear off, but the porcelain or ceramic doesn't wear off. So this is the biggest advantage. And the next, please. This is a picture where we have given porcelain laminates for a lady who is about 42, 43. And this psychologically also uplifted her in many ways. She was having a lot of trouble in her social circle because of the smile, and she wouldn't smile too much. And once this was done, her confidence levels also went up an all-time high. So this is one of the main reasons why middle-aged women come to us for cosmetic work. Next, please. So aesthetic crowns are a little more advanced than porcelain or ceramic veneers. So when you have heavily damaged teeth or heavily treated or eroded teeth, so we would normally advise a root canal treatment and then some crowns on them. So at that point of time, porcelain laminates may not be the right choice. So we do root canal, and then we take some measurements and fix the crowns. So this is a little more long-lasting option, and also can be used for posteriors. Generally, laminates of composite or ceramic cannot be used for posteriors, whereas aesthetic crowns can be used anywhere in the mouth. And normally these are different types, acrylic, ceramic, fused to metal, but the most common is metal-free ceramic or zirconia, which has no metal, so no shading. It reflects the inner shade. The translucency is extremely good, so makes it look extremely natural. Next, please. So this is again another 55-year-old lady who came into us with a very disturbed mind because of her teeth, and she wanted crowns done. So laminates were not possible, so we went in for crowns. So you can see the result here, and her entire upper teeth have been fixed with crowns. And in the lower, you can see it's only the lower anteriors. The lower posteriors still have the same color, and it's the same. So that's because of the cost. Since the cost, she had a budget in mind, and we had to do the maximum to fit into the budget. So this is what we have done for her. Again, a very satisfying treatment. Next, please. So many a times, replacement of missing teeth is not considered an essential part of somebody's lifestyle. People feel that once you have 32 teeth, and if you don't have a few, it doesn't matter. That's extremely a bad idea, because every tooth has a role to play. So when you lose a molar, then your chewing efficiency comes down by 10%. When you lose 4 molars, then your chewing efficiency definitely comes down by 30–40%. So this is not, this kind of education is not given to our, I mean, leave alone the public, even the doctors don't know about this. So it's very important that replacement of missing teeth are advised, at least up till the 2nd molar. 3rd molars we don't replace, at least up till the 1st or 2nd molar in youngsters and adults, and in very elderly people, 75 plus, at least till the 1st molar. So this is the sequence that we do, and there are different types of replacements. Next slide, please. So these are the types of replacements that we have. We have fixed, semi-fixed, and removable. Removable dentures are no longer in vogue. Fixed and semi-fixed dentures are in vogue right now. And in fixed dentures, we have 2 supported.
Yashwant, you have one more. Can you quickly talk with the concluding remarks?
Yes, please. So can you go down to the next one? Yeah, these are tooth supported bridges where we take support from the teeth and give the dentures. Next one, please. These are dental implant supported crown and bridge, where we use the implant to get into the bone, and then that is taken as support like the tooth root, and then a crown is fixed on top. Next one, please. These are removable dentures. We don't advise this unless for commercial cost reasons. Next one, please. These are transitional supported dentures. These are for patients who have cardiac issues, who have multiple other morbidities where you can't go in for a fully fixed denture. We give something called a transitional or temporary implant and fixed teeth. All this is done in about 12 hours or so. It's a daycare procedure. They come in the morning and they go with teeth in the evening. This lasts only about 3 to 5 years, but it works extremely well for elders. Next one, please. Orthodontic treatment. There are 2 types of orthodontic treatment. I'll go quickly onto it. The next one. So we have something called aligners or braces. I'm sure all of you know about braces. So I'll go on to the aligners. Can you go to the next slide? Next one. Next one. Next one, please. Yeah, these are post-pre and post-op of after braces treatment. Next one, please. Yeah, so aligners are a more modern and new method of treating malaligned teeth. So we don't use braces. We use a removable plastic sleeve, which is fixed on the teeth surface. And these are changed every 15 days. And depending on the condition, I will probably give them about 20 or 30 or 40 aligners. And with pressure from the plastic sleeve, teeth move and get aligned. So this is a new and an amazing method of treatment, especially for elders, women, men together, especially for elders. Can you go to the next slide, please? This is one of our patients we've treated. She's about 59 years old. She's a retired government servant, didn't have too much time during her work to get her teeth aligned. And then she came back to us at this point of time. We gave her some aligners and got the work completed within 6 to 7 months. Next one, please. Yeah, so to conclude, next one, please. To conclude, like I said, it's very important to understand that cosmetic dentistry is not just for youngsters. It's a very, very useful tool to bring down the health, the mental health, and also improve the efficiency of chewing efficiency for elders, middle-aged women, elders, and this kind of advice has to go from the gynecologist, also from the gynecologist side, because most of the time they go to you for advice and then they come to the dentist only when there is pain or some suffering. So if there is some education from your side, this will really work. Thank you so much. This is our new center and this is my team. I can take any questions if you want.
Dr. Yashwant, you have only one question. Can alignment of the teeth be done in elderly people?
Yes, ma'am. My oldest or elder patient is 59 years old. So with aligners, with braces, my oldest patient is 62 years old. The only problem is it takes a little longer for adults in cases of elders. But also the most important criteria is the gum health. If the gum health is good, we have no problem.
So that was a very excellent presentation, Dr. Yashwant. Thank you so much for sharing all the important points. And it was a great honor to have you and to throw more light on this cosmetic aspect of dentistry, which is very, very vital as we get older. I think everyone needs a good cosmetic dentist, in fact. Thank you so much.
Yeah. As we grow old, all this osteoporosis sets in the jaw also. So
Yes.
your teeth gets loosened. I always wanted to hear from a good dentist person. I heard so much interesting message now. Thank you so much. It was really useful.
Thank you very much. Thank you, Dr. Mala. Thank you.
Thank you so much for joining us.
Ipsiba, madam, shall we go to the next speaker, Dr. Sendilvel Kumar? Yes, Dr.
Yes, Sambat.
Yes, madam. Dr. Sendilvel Kumar, we will be talking on keloid prevention, current and emerging therapies. He was the plastic surgeon from Trichy. He is serving in plastic surgery department for more than 30 years. He did his MBBS in Tanjore Medical College, and he has many gold medals during his UG and PG. And he is one of the founder consultants of Kaveri Group of Hospitals. And he was the Trichy Secretary of IMA branch, IMA on 2018, and he has received the Best Secretary Award from State IMA 2019. And for his pandemic work, he has received a National Chairman Special Award for the recognition of the COVID time. Back to Dr. Sendilvel Kumar. Dr. Sendilvel, stage is yours.
Yes, madam, I am ready. Am I audible, madam?
Yes, you are audible. You are audible, and your slide is also seen.
Okay, madam. Respected President of the Chennai Menopause Society, Professor Dr. Epshiba, the Vice President, the Dynamic Secretary, and all the active members of the organizing committee of this conference, respected teachers, seniors, and friends. Greetings and best wishes from Tiruchirappalli for a great conference of academic treat. I am given a tough topic about a tough task of keloid management, which is one of the most difficult fields in the field of plastic surgery. Keloid meaning crab claw, coined in 1806. Whenever you describe a scar with all possible adverse adjectives, it will describe a keloid. Yes, keloid is an abnormal scar, irregular, thick, hard, raised, proliferative scar growing beyond wound margins without wound regression. I still remember our surgery professor giving us a useful acronym when TV was introduced in late 85s. At that time, he gave us this tip. Keloid is TV. Any scar that is itching, spreading, tender, and vascular is invariably a keloid. And naturally, all good adjectives will be for an ideal scar. It should be fine, it should be soft, it should match with the surrounding, should not cause any contracture, and it should be painless. This lady came to us 2 days after a road traffic accident with a tensed rough suturing on her forehead. We removed, asking for plastic surgery. We removed all the sutures, debrided the wound, recreated the defect, then did a revision suturing to get a scar like this. If you closely watch this scar, patient is quite happy. She was satisfied for this acceptable scar. But as plastic surgeons, we are not that much happy. The reason being not surgeon's factors is because of patient factors. First, the patient came to us 2 days after the injury. Number two, the suturing had been, the first suturing had been done very roughly in a tensed manner using heavy sutures. And the third one, it is in an unfavorable site of injury. For example, the relaxed skin tension lines on the forehead or on the transverse axis, whereas this injury is on the vertical axis, totally unfavorable for the plastic surgeon to give a beautiful scar. So when you consider ideal scar as a good sister, this sister has one small brother and a big brother in the same family. The small brother is a hypertrophic scar, which has all the following characteristics like this. The essentials being they are thick, they are raised, they are distinct, they are contracting, and they are painful. So when you compare the small brother with the big brother has the following characteristics. The important differences being they are thick as well as irregular. They are distinct as well as spreading type. It spreads beyond the zone of injury. And even hypertrophic scar may regress with time. Keloid never regresses with time. Any wound that penetrates the dermis causes scar. This is a pure scientific truth. We are just trying to modify the wound healing by our proper techniques so that the scar ultimately becomes acceptable. So it is a natural way of repair of the wounds. This healing process is orchestrated by a sequence of events. Ultimately and basically, scar is just collagen deposition and organization. Few words about collagen. It is secreted by the fibroblasts. Nearly 14 subtypes of collagen are there. In that, type 1 and 3 are main for the human skin. They are in the usual ratio of 3:1 in an adult skin. And this ratio is very, very important in determining the strength, elasticity, and type of healing. We not only, aspire for a good scar, we also aspire for a good strength, especially in laparotomies. Whereas in a fetal wound, the ratio is just 1:1. That's why they are scarless in fetal wounds. When we have a look into the wound healing process, it has 3 important phases. The early phase is inflammatory, starts from 2 to 5 days. The interim is proliferative, lasting from 3 days to 3 weeks. And the delayed phase is the remodeling phase, which is from 2 weeks to 2 years. And this wound healing cascade is the principle by which, we do the dressings, we do the timing of suture removal, and we are giving instructions to our patient, how long they should take rest. Everything is based upon this physiological wound healing process. And as a surgeon, what is our aim? Our aim must be the inflammatory phase must be brisk, but it should be less pronounced. It should not be awesome. The proliferative phase must be good, but it should be optimal. Whereas the remodeling phase should not be overwhelmed. It should be regular and disciplined. These are all our expectations in a good wound healing. There are many agents which are elucidating all these events, but important in them are cytokines in the inflammatory phase, fibroblasts in the proliferative phase, and collagen in the remodeling phase. Why fetal wound is scarless? Fetus has internal and external environment affected by serum and amniotic fluid, and the fetal serum contains large amounts of regenerating stem cells and high level of growth factors, hyaluronic acid, etc. And the important point is that they have a reduction in the amount of platelet-derived growth factor and transforming growth factor, fibrinogen. This is the main reason why fetal wound healing is scarless. Of course, amniotic fluid is ultrafiltrate of plasma. They also contain increased stem cells and high level of growth factors. And as a surgeon, we should know about certain keloid prone areas. Even the finest of plastic surgeons cannot give a good scar in these areas like mid-sternum, deltoid, shoulders, and ear lobule. And there are certain keloid never areas, palm, sole, axilla, and scalp. Abdomen comes in the less prone category. So by default, all our OGCNs are fortunate. And thank God, it is equally poised in the incidence. And the peak of age is 20 to 30 years to get a keloid. And the time of occurrence after wounding is 6 months to 2 years after injury. Thereafter, it proliferates indefinitely. And as I already told, the basic pathology is deposition of collagen in the dermis beyond the boundaries of the wound in an irregular manner. That's what this histopathological slide describes. And looking into the pathogenesis of keloid, there are so many theories formulated. When there are so many theories for a single cause, then no theory is authentic. Hope you will agree with me. As surgeons, let us better know keloid is totally abnormal. This is enough. So how to prevent keloid? Coming to the topic per se, this is how to prevent keloid formation in our wounds. The first point is always aim for primary intention of healing. As you see the wound in this child, it's a small wound, not bleeding. So it is a general tendency to say, it will heal by itself. Don't worry, don't do anything. That's a wrong piece of advice. The aim must be primary intention of healing. Naturally, either skin suturing or skin glue approximation should have been done to get a fine scar. Then placing incisions along the relaxed skin tension lines, otherwise called RSTL. This lady came to us with abdominal obesity and huge divarication of recti. We have done liposuction, lipodermectomy, abdominoplasty, and umbilical translocation. And we took all steps to place this long scar along the skin tension, relaxed skin tension line, so that she gets an acceptable soft scar. So placing incisions along RSTL is mandatory. Third comes gentle tissue handling during surgery. That's why plastic surgeons are very fond of skin hooks and fine forceps, and they are really afraid of holding the skin with Alice and heavy toothed forceps. Thorough wound debridement is mandatory. It is clearing all the germs from the exposed wound. Not only that, it also lessens the phase of inflammation. Good quality sutures, by which we mean synthetic, non-absorbable monofilament sutures. They are the best favorable sutures for us. Naturally, ethylene and prolene are the favorite sutures. And nowadays, I find a lot of our obstetricians closing laparotomy wounds and cesarean wounds with monocryl, a monofilament material, which is a welcome move. And good suturing techniques. Whenever you want to close the skin, a good subcutaneous approximation is really very good. Unless you achieve a good subcutaneous approximation, a subcuticular stitch may not help you. It will result in a lot of wound collection. As we have done in this revision suturing, this lady had done really very well. And absolutely no scars are seen on her forehead, despite it is an unfavorable injury per se. Tension-free closure for the operated wound is always mandatory, because a wound that is closed with full tension causes increased cytokine release, and it invites drastic fibroblast response. Occlusive dressings are better than keeping the wound open, because occlusive dressings provides moisture in the wound. Thereby, it helps in re-epithelialization of the operating wound. Our aim is to get maximum re-epithelialization and less of fibrosis in an operated laparotomy wound. So occlusive dressings, as far as possible, are better choices. And keeping the scar moist after suture removal by using moisturizers and creams, they are also important. They also do the same purpose. Then pressure therapy to the scar. If he is a non-keloider, then scar oil massage 1 week after suture removal, or applying pressure garments. In keloiders, pressure therapy causes decrease in the blood supply to the scar. Thereby, it reduces the collagen deposition and remodeling response. Silicone gel sheets, it has several functions. They are very useful in preventing keloids. Avoiding direct exposure to sun, it causes hyperpigmentation of the scar. Especially, it is important in facial scars. Of course, abdomen is a closed area. There are umpteen number of scar lessening ointments in the market, and their usage and usefulness are debatable. I leave it to individual surgeon's choice. Beware of keloids in elective surgeries. In emergency surgeries, we don't have any other option but to operate. Whereas when we are contemplating on elective surgeries, let us have a look or let us inquire the patient whether he has abnormal scar elsewhere in the body. Family history of keloids, beware of that, and beware of steroids. So, 16 பெற்று பெருவாழ்வு வாழ்ந்து கீழடை உழைக்கும். So, current treatment for keloids, there are two modes of management, non-invasive and invasive. Naturally, non-invasives will be favorable and they will be painless. Pressure therapy and silicone sheets. In invasive, intrakeloidal steroids and surgical scar excision and intrakeloidal injection. Pressure therapy had been in practice from 1970. 24 to 30 millimeters of mercury is the recommended pressure in the garment for a period given for a period of 6 months to prevent keloid or to treat keloid. Both are fine. And pressure magnets are given for ear keloids. I'll be happy to say as a plastic surgeon that we got 98% control of ear keloids so far. Silicone therapy treatment from 1980. It prevents evaporative loss from the epithelium, and lab studies reveal decrease in transforming growth factor beta. Both gel as well as sheet, both are efficacious. Intrakeloidal steroids, first line of management for keloids, have been in practice from 1960. Triamcinolone is the drug of choice. The dosage is 10 to 40 milligrams. It shall be injected into the papillary dermis, of course, with special syringes by multipuncture technique. And it is injected once in 2 weeks, totally 6 doses, totally 3 months of treatment program. But however, the response is only 50%. We are able to get only a pass mark and never distinction. The mechanism of action in a new scar, the keloids reduce the inflammation. The steroids reduce the inflammation and reduce the proliferation. In old scars, it checks the collagen deposition and remodeling. And this is the multipuncture technique. We load triamcinolone mixed with local anesthetic in a special syringe called dermojet and give them shots like this, nearly 70 to 80 shots in one go. The initial 10 shots may be painful. After that, local comes for a rescue and we are able to do a painless procedure. Sometimes instead of keloid, intrakeloidal 5FU was used. It inhibits fibroblast proliferation. And in combination with steroids, it offers good results up to 70%. But these injections are painful. Then somebody used intrakeloidal bleomycin. The response rate they claimed was up to 80%. But there is no pain and pruritus in this combination. So our current group of CMC velour plastic surgeons, they follow this as a protocol. Intrakeloidal interferon. Here and there, it has been in usage from 2000. The major problems are high cost and heavy pain. What are all the emerging therapies? Low-dose radiotherapy is one of the promising emerging therapy. Because we have seen in this pandemic period, certain COVID-infected lungs that were refractory to the prompt medical line of management or supportive line of management, were responding to low-dose radiotherapy. Several papers have come in at that time. The reason they say the low-dose radiotherapy is able to control the cytokine storm. The same cytokine storm may not be there in a keloid. A cytokine rain or a cytokine thunderstorm may be in a keloid. So low-dose radiotherapy helps. Low-dose X-ray also there. Laser therapy is there. Cryotherapy is there. Interferons, deep insulin and colchicine. The list is endless in emerging therapies. These are several of our outpatient noises which we often hear. Doctor, I thought plastic surgery did not leave any scar. With that the belief, I came to you. My scar, I'm not happy with my scar. Then we sit with them for several minutes, explain to them any injury that causes a breach in the dermis is prone to develop a scar. We use certain good techniques to minimize the scar. But we never assure that we will not leave behind any scar. Plastic surgery is always a battle between beauty and blood supply. Another comment, you are a better plastic surgeon. I can hardly see any scar in my eyelid. The previous one left a big scar on my shoulder. We smile at them and tell them, explain to them that eyelid is a less prone area for keloid, whereas shoulder is a high prone area for keloid. This is very risky. Doctor, I know I get keloids. You see the keloids in my arm. Patient pointing to a thin, pale scar in his arm. When we inquired, he said, I got the voice information from Google Access. We are really worried about such patients. We generally try to neglect such patients giving our treatment because we tell them that we are really incompetent to give him the best scar as he likes. As Oscar Wilde said, when we blame ourselves, we feel that no one else has the right to blame us. So to wrap up, carry home points are keloid is one of the most difficult problems in the field of plastic surgery. The etiology is not very clear and the cure is also not absolutely sure. So 100% cure cannot be achieved with keloids. Keloid is an abnormal scar, but not malignant. It can occur when you operate on keloid-prone areas. It can also occur in other areas for patients with keloidal tendency. It is always better to take all precautions to prevent excess scar, since it is difficult to predict who will develop keloid. The time spent during surgery is more worthwhile than excuses and explanations later. There are two important factors that compound a good surgical scar outcome. The first and important one is the surgeon factors. The surgeon factors with all the good Samaritan activities, aiming for primary intention of healing, gentle tissue handling, good sutures, good technique, tension-free closure, good dressing, good post-operative care. But there is one more factor that is remaining, that's called patient factors. Magnitude of the injuries, crush injuries and avulsion injuries, they behave very bad. We cannot give excellent scars. Personal wound care by the patient, that also matters. And genetic constitution in him, if he is a keloider, he has keloidal tendency, even the finest plastic surgeon cannot give 100% result. When these two factors are in amicable equilibrium, then we can give 100% guarantee for the scars. So whenever the anxious parents come to me with their children asking, doctor, will I be able to get 100% free scar in my child? I always give them 70% assurance, because 7 events in this chart are in my responsibility, whereas the 3 events are not in my hands. Non-surgical options score better than surgical options, and surgical options are not bright, as its response and recurrence rate are nearly 90%, and the recurrent keloid is more awful than the original keloid. Low-dose radiotherapy seems to be promising in emerging therapy. And being a dexterous and dynamic surgeons, we should not allow our patient scars to transform us into someone which we are definitely not. And whoever finds a cure for keloid is sure to get a Nobel Prize. I once again thank the organizing committee for giving me this pleasant opportunity, and I thank the learned audience for their kind attention. Thank you very much.
Thank you, sir, Dr. Sindhil, regarding the prevention, current and emerging therapy of keloid. It was wonderful. At present, I don't see any questions in the chat box. If it
because
comes,
it is a tough topic, madam.
Yes,
and nobody is interested in keloids.
So all are interested in plastic surgery now, sir, regarding the keloid. Anyway.
So, one question.
Yes, madam.
Madam, question. In the post-operative, immediate post-operative period, to prevent the keloid, shall we use? Many people are using that contratuberous steroid creams. Will it prevent keloid formation, sir?
That's what we put it, madam. So many ointments are there. As a plastic surgeon of 20 years experience, I have never found any ointment, lessening the scar amount or giving forth the fine scar. That is why I said it is left to individualistic surgeon's opinion. I'm not really happy about such ointments, madam.
Thank you, sir. Thank you. Thank you, sir.
It's great pleasure to participate in this conference, madam. Thank you very much. Thank you.
Before Dr. Annie irukangla?
Madam, I can't find any.
I'm not able to see her name.
Please move on to the next
session.
Then we can introduce Dr. Ragini Agarwal, I think. Huh?
Okay, ma'am.
Session 2. Session 2 is about aesthetic genital plastic surgery. It is chaired by Dr. Sampath Kumari, Dr. Dhanalakshmi, Dr. Premalata, and Dr. TK Shanti Gunasingh. Dr. Dhanalakshmi.
Atma, Dr. Dana is not there, I think. Dr. Premalata and Dr. Shanti can introduce. Two speakers.
Okay,
madam.
Okay, madam.
Okay.
Okay, Pa, we will take over then. Okay.
You can start.
So, this session on aesthetic genital first talk, food reduction. And we know that aesthetic genital plastic surgery is gaining lot of acceptance now because it appears, it actually helps in enhancing appearance, reduces discomfort, and of course, sexual pleasure too. So we have Dr. Ragini Agarwal to talk on this important topic. Can you post the CV of Dr. Ragini?
Yes, madam. Yes.
Yeah. She is Director, Pratiksha Hospital, Gurgaon, and Derma Science. And she's an OGIan who is trained in cosmetic gynecology and laser. And she was a dynamic Vice President Foxy in 2020. And she's President of Indian Association of Cosmetic Dermatologists. Dr. Ragini, please.
Thank you so much, Dr. Shanti, of meeting you after such a long time.
Yeah.
When Viplo used to be study in Chennai. Very good evening to all of you. Thank you, Dr. FC, for giving me this invitation. And Chennai is really so close to my heart. My son has graduated from KMC. So I used to come Chennai so often. And seeing so many friends here, Dr. Sampath Kumari, Dr. Mala Raj, and Dr. Shobna. So good to see you all. I'm just sharing my screen. It is such a vast topic, but I will try to do justice in 20 minutes. Yeah. With blessing of God, I will start my presentation with a gratitude to each and everyone from where I have taken the material or photographs, or my teachers who has guided me, and friends who have supported me, and all of you who are sharing your time with my vision. Thank you so much. So coming directly to the topic, the labioplasty and the clitoral hood reduction. It's a topic which is today for last 7-8 years is too much in the discussion. And it is something which is not totally aesthetic. It is something which many a time women really want. And she needs it, but she doesn't know where to go and what to do. Although thanks to social media and everything, today people are aware of this thing. But I remember the day in 2000 when I did my first labioplasty. for a person who is not able to get a proper intercourse, and she came as an infertile patient and she got conceived after the labioplasty. I will start with the introduction of the vulva. Vulva is a stepchild to the gynecologist. It is most visible female genital structure, but it has received the least attention in the medical literature, and it is considered a forgotten pelvic organ. When we talk about the vulva, we always talk about the vulvovaginitis. It's never vulvitis. So in recent year, with the aesthetic gynecology, the interest in vulva has increased a lot. And when we talk about the vulva, it is a very, very multidisciplinary organ with a disease. So many people want, other discipline want to discuss the vulva in their seminars. So what is vulva? Is basically it has so many sub-organs in it. No other reproductive organs have so many organs in it. And what is special about it? It has a keratinized squamous epithelium and opposed to vaginal mucosa. No estrogen receptors, and labia minora is specifically when estrogen is withdrawn. There's atrophy and dermal fibroblasts have estrogen receptor. So outerwear, it has no receptors, but in labia minora, there is estrogen receptor, which we should remember. And it is extremely vascular structure. So it is a different epithelia, it is rich in sebaceous glands, but no hair follicles. And its epithelium of the vestibule is neither pigmented nor keratinized, contain eccrine glands. So it is a visible structure and has so many structure in it, from mons pubis to going to the forehead, and there's a tuberosity, urogenital triangle, and we should always remember embryologically this is a part of the urogenital sinus. So here we are going to focus only on the labia minora and the part of the clitoris. So labia minora is two small cutaneous folds, because if we are going to operate, we should understand the anatomy. And I am very, very sure that the anatomy of the labia minora, none of us have ever given a really a very, very keen interest and read everything about the labia minora, except that it is the inner lip. So it is the two small cutaneous folds that are situated between the labia majora and the vaginal orifice, differ widely in shape and size from the woman to woman. Ideally, they should be completely covered by the labia majora. And their function is to close the vaginal opening to protect against infection and prevent the vagina from drying out. And between the two labia minora is the pudendal cleft. We should always remember that pudendal cleft, that if this pudendal cleft is so too wide, then only your labia minora is going to be projected. And it is homologous to the penile urethra and the part of the skin of the penis in the males. Laterally, they extend obliquely from the clitoris toward the rear for about 4 centimeters on the either side of the vaginal orifice. They are shorter and thinner than the labia majora, and at the clitoris, the anterior portion of each labia minus divides into 2 segments. So what these 2 segments? These are the 2 segments who are going to form the clitoral hood. Clitoral hood is nothing. It is an extension of the labia minora only. So proximal to the clitoris, they cover the clitoral shaft, which arches outwards like a half cylinder. And their proximal segments form the clitoral prepuce. In between the glans and the small shaft of the clitoris, that is the small penis, lies. The distal part of the prepuce in turn forms an almost circular fold of the skin that closely drapes the glans of the clitoris and is known as the clitoral hood. Why it is very important to understand that if you cut this clitoral hood too much, it is going to make the oversensitive that woman, even it is impossible for her to wear any dress. There's a great variation in the shape and the length of the clitoral hood. Sometimes it covers only the proximal part of the glans, and sometimes it covers the entire glans, hanging over it like a curtain. Here, these type of the clitoral hood is really need a reduction if only patient wants. And the cavity formed between the glans and the inner side of the clitoral blood is called the purpural chamber. And the sebaceous glands colonize the neck of the glans and produce sebum and smegma, which commonly collect the purpural chamber. So sometime your patient will come in with a vulvovaginitis regularly. You have to examine that chamber also. Maybe it is having something and having an infection. With advanced age, the clitoral hood leads to descent and the lateral parts of the clitoral hood merge into labia minora surrounding the glans. And sometimes there's a smooth transition in this junction, and at this junction or at other times a different step. Now this labia minora continue to run downwards along both sides of the vaginal vestibule to the posterior commissure and the perineum, where they meet in a bridge of the skin, and that is called the frenulum of the labia minora, or which we commonly call as a posterior forecheck. Now the height of the labia is greatest immediately below the clitoris, and it becomes less as the labia run inferiorly. We all know that the posterior foreset is hardly 2 to 3 millimeter of the labia minora is there. It's a very small line, and distal extension of the labia minora radiate across the foreset and along the raphe as far as the anus and merge into the anal skin. So the skin of the inner labia is considerably thinner and than that of the outer labia. It is hairless and inner aspect is covered with the vaginal skin, which I have already told you. Now there's a loose connective tissue with a varying thickness, and it all depends in a different woman as a different consistency. Contains weaves of the collagen fiber, abundance of the blood vessel, and represent the subcutaneous filling material of the whole external genitalia, likewise surrounding the entire clitoral area and the clitoral shaft. With increasing age, but even in some young women also, the inner labia can grow excessively and protrude beyond the shelter of the outer labia. Apart from this unaesthetic appearance, this may result in the functional impairment like difficulty in the intercourse or chafing with the tight dress, especially women who are wearing today the tight jeans and everything. Many a time they come with this problem. It is often measured differently. The labia minora length is the maximum distance from the origin of the labia at the start of the interlabial fold until their insertion into the perineum. That is the length. And when we talk about the height, the maximum distance from the base of the interlabial fold to the free edge of the labia minus. And distance is best measured with the patient standing. So whenever you're going to operate, you are going to examine that patient very, very properly. Patient in the standing side, and you have to little bit crouch down and see that area, how it is hanging outside the labia majora. And then patient has to lie down in the lithotomy position, and you have to take a picture on the oblique also. So when we say that the hypertrophy, it has no internationally recognized definition, but it is considered when the height is exceed more than 2 centimeters from the base of the interlabial fold. The inner vaginal lips generally start to be visible with the shelter of the labia majora. But one thing you always remember in the postmenopausal woman, because of the age, that labia majora become an empty sac. So labia minora automatically start protruding. So those women coming in the perimenopausal era, they need a side by side labia majora treatment also. So if they measure more than 2 centimeters in height, therefore the labia minora can be described as a hypertrophy. Again, always remember, you are not going to offer any operation to anyone unless they come to you and talk about this thing. The clitoris is the only organ in the human body that serves exclusively for the sexual pleasure. It is the 3-dimensional structure in the shape of the inverted Y. It is a short cylindrical erectile structure, 2 to 3 centimeters in length at the superior portion of the vestibule. Why we are talking many times in labiaplasty and the clitorohodoplasty is done together. At that time, you have to remember the position of the shaft, its angle of the shaft, and how much it is exposing. And sometimes we have to take the stitch like that shaft will be little downwards and the inwards. And the clitoris consists of the base of the 2 pleura that attach to the periosteum of the symphysis pubis, like penis. The body of clitoris consists of the Many nerve endings are there. Age, weight, oral contraceptive use do not change its anatomic dimensions. So this is the clitoris, which we have not read when we are a student. It was really diagnosed like this after many, many years. So we should always remember the vestibule area, because if you really do lots of nerve dissection and this area can produce a vestibulodynia in the patient, and patient will come with another problem to you to the treatment. So this one thing always remember, whenever you operating with a patient, the nerves, the vessels, which many a time they cut, and they can create other parasitic problem or the super sensitive problem also. So this is just like a picture to show you the front, the oblique look, and when we operate afterwards. So like any operation, you have an evaluation and the preparation. Although evaluation in the aesthetic surgery is not very difficult, patients are usually having no problem, but you have to ask for all the comorbidities, go for the smears, go for the pap smear, because anything happen, they will come and say it has happened because of that treatment. And if patient has any vasinitis, your operation get infected and it will lead to the non-healing or scarring. And patient may be come with a functional or aesthetic reason, but sometimes there are the psychological issues also that you have to discuss, because you are not going to operate on any patient who is having a body dysmorphic disorder. Now the area should be fully shaved. We prefer local anesthesia, but some patients want a GA, then you have to go with a GA. In the local anesthesia, we apply a numbing cream before giving the injectable anesthesia. And basically you have to ask about the aspirin or any other anticoagulant. If the patient is on that, please stop it at least 7 to 10 days before. Photo documentation is must. Standing frontal view, lithotomy, lateral oblique, and the frontal before and the after operation, and post-operative follow-up visit. If patient, usually the patient does not come back if they are happy, they have no complication. So it's very difficult to get the 6-month photograph, but if you are in the touch of the patient, they can take their photograph and can upload to you. Now medication, good analgesic, perioperative and the post-operative is required. Antibiotic cover, although many people say they don't require, but it should be given, and I always give. Now the consent, that is the most important documentation from your side, and try to take by yourself. Perioperative briefing session is very much required. First session and then again before operation. Swelling, pain, post-operative bleeding, hematoma, disorders of the healing, scars, infection, asymmetry, and basically dimple formation, over under correction, and the revision operation. Now it is an outpatient procedure, but always give an emergency contact number, easy access to surgeon, and follow-up visit should be the next step. Equipment, not much. You really require a good marking pen, which is waterproof. Instrument, nothing. Tooth forceps, fine scissor, needle holder, mosquito forceps. You can use your laser to cut it, but it will really going to increase the charges. So I never use a laser. Cautery machine, OT table, light, pulse oximeter, and always you're going to have an emergency trolley with you. Surgical goal is the achieving best possible function, the optimal appearance, maintaining the sensitivity of the area, and always evaluate labia majora, because sometimes labia majora is the culprit. You need the augmentation of the labia majora, not the cutting of the labia minora. So there's no ideal appearance. Patient's own preference is the choice. Anatomical consideration for surgery, proximal to clitoris, at the level of the clitoris, and distal to clitoris. There are the 3 areas which we have to keep in the mind. And what is the relation to pudendal cleft? As I have told you, see the picture. In the one side, you are not able to see anything except the labia majora, but the other, when it is protruding like a penis, it may cause an aesthetic appearance in a patient mind. Now there's a lots of variation in the clitoral hood. as you can see here. Then coming to the level plasty, the first thing is the marking before injecting local. Otherwise, it will swell up and you cannot able to do the marking. Always mark midline along the clitoral shaft and the interlabial folds for orientation. One can show the markings to the patient also. Please tell me before 5 minutes. Now coming to the because we are doing in the local and it is an aesthetic surgery, patient has to be very, very comfortable. They are very, very afraid of the injections. So make your labor, this OT should be a very pleasant place for them. You can play a light soothing music. Your nurse should be very, make the patient very comfortable, can hold the hand and put the numbing cream like Pralox before 45 minutes. So area is little numb. Then only you can give the injections. And 10 ml 1% lidocaine with adrenaline, 1 lakh we have given, and the 27 gauge needle with 40 mm length. And start from the inner aspect of the labia minora, because you can go up and you can cover everything and you can anesthetize more of the nerves. So coming to the technique, always remember reduction in the whole length of the labia from the origin to mons pubis to the perineum. Why? When you only do the cut on the down size, the above size become a hood-like structure and your clitoral hood become heavy and it start protruding. So patient is coming for one thing and another thing you are going to iatrogenic produced. So what I'm going to discuss here, the composite reduction labial plasty is starting from the above to the end. And in this, I'm going to cover the more of the clitoral hood reduction also. So if you see this patient, it has everything is there. The above is heavy, the lower is heavy, and how we are going to do it. And we always do the marking like this and start incising from the lower side. So when we cut the incision, there's few things we have to remember. We are always keep in the mind of the vasculature. And as far as we have to see that we should not cut all the vessels. Although there are other techniques which also I can do in some time, like the simple trimming. If a patient does not have lots of problem, very young, no above part is heavy or there's a clitoral hood. And it's a very simple operation and it's a beginner operation also. So there many a time we cut the vessels also. What happened with that? That patient many a time lost the sensation also because we cut the nerves and we cut the vessels also. Here we really going step by step, taking out the skin and going under the submucosal area. And after if you see the second place, where the upper skin is removed, lower skin is removed, then it will be taken near, the edges are taken nearly and we do the stitch. So the main thing is that here we have to remember how to position our clitoris also. So in this, if you see, the upper part is little bit taken down and it will be stitched to the side and the lower part. And when we stitch this mid part, only then we go to the upper part and stitch it. If we stitch upper part as in our normal surgery, many a time what happened, there's a ear-like structure comes and it is very difficult at that time. You have no markings, how to stitch it, and it can make an uneven surface, or sometimes the both type of the labia is not in a normal shape. One may be more, one may be less, and dimpling might be occur. So it's a lateral side. We are taking the sutures and mostly there we are using 3-0 or 4-0 suture of the multifilament absorbable. Mostly I took the Vicryl and we'd go with the mattress suture here. There's an interrupted mattress suture. What is the advantage of taking this suture? Not in the continuous suture, which I really prefer in taking in a trimming method. Here, when we are doing this much of the surgery, the swelling, hematoma, discharge, they are little more common. And here patient really, they come with the mind that there is not going to be any complication, because when anybody publicizes their surgery, they make it so simple that it is nothing. But any surgery, as a surgeon, we all know that can cause bleeding, infection, hematoma, discharge formation, swelling. And so if there's a small gaps and you put a pressure bandage, most of the, if there's some collection is there, it will come out by itself. So if you see this picture, this is the final version of the operation. So how much time is left?
5 more minutes, ma'am.
Pardon?
5 more minutes.
5 minutes are left. So it is very important to always have your patient photographs, because only then you can compare and tell them what, how it was looking beforehand and how it is looking afterwards. So most important step is to prevent pulling apart labia minora. Because if you stitch it like this, it will become apart. It will not come inside, because it is all the stitching is going to have little bit fibrosis also. And you see, it should not be flattened, but when it heals, it will come like this, not like this. Okay. So the same patient is in a standing position, in a lithotomy position. It is a pre-op and it is the post-op pictures. So now coming to the dressing, we have done the operation. Clean area completely, dry it completely. And how you are going to dry it? You're not going to rub, you're not going to just put a gauze and just press it. This pressing will give one more thing, it will reduce your swelling. And another tip which I want to give you at this time, I have a ice packing always ready with me. And the first ice packing I give by myself at least for 5 minutes at the meantime. And give local anesthetic again. So patient will not have an immediate post-operative pain. Because post-operative pain in this operation is really too much. And we have to put a gauze dressing and a panty which is really going to snuggle it. And if you think that this dressing can follow, you can do one more thing. As a gynecologist, we are very fond of putting the pads. So after putting this gauze dressing, you can put a pad over it and tie that pad above the band like we put after our delivery patient. Don't put any micropore or anything in that area to strap it, because this strapping can cause problem and the chapping of the skin sidewise. And never use any alcohol on the private part, which we all know. And gauze dressing with help of the panty, we can tell her to buy the disposable panty, and she can change that panty many a time. That panty will add as an extra dressing also. And she can use that ice pack at home also. Now, post-operative management, that is also always remember, tell them to use this thing, cooling. Number one is cooling. Firm panties. Should wear gauze compresses at least for 14 days to make those stitches separate. So the area can heal nicely separately. And local antibiotic ointment, I prefer nadoxin. Keep area dry all the time. After going to the urine or something, you have to make that area dry. The hair dryers come very, very handy. Now each side should be squeezed along the length gently to smoothen up and reduce the swelling after 14 days. And give a confidence to her also that area becomes absolutely normal. Abstinence 6 to 8 weeks, what the literature says. But in my practice, I always give 12 weeks because I don't want it to be my incision to do anything with the until it is properly, absolute properly healed. No tampons should be inserted. It can again tear your skins. No shaving, and patient will only can trim their hairs, no bikini wax, no shaving, nothing, and not apply even any other those appliating creams also in this area. If patient is too hairy, I always ask them to go for the laser hair reduction before this surgery, and they all agree. So coming to the alternative techniques, trimming, wedge shape, that is another popular thing, and there's no end. I'm not going to talk even about them because they're all useless. Just because I like something to put my name, Ragini's technique, I'm going to make some flap up, some flap down. So these are the three main techniques which people are using. Mostly trimming and the wedge shape is the most common one. But why I have given this technique? Because I have to talk about the clitoral hood also a little bit. And,
Madam, can you try to finish, madam?
Yes, I'm finishing. A word about the clitoral hood plasty. Excess folds of the clitoral hood or prepuce can be reduced separately also because it creates a bulge and excess tissue is marked according to the individual anatomy. And we will just make a inverted Y-shaped structure and cut and do a plasty. There's a risk of bleeding, hematoma, infection. The same thing is there. If you do the over resection, the life of patient is not going to be good. But becoming the sensitive is good, but becoming the oversensitive is not good at all. So this is one practice where you have to give lots of interaction with the patient, lots of things, because it is not something that patient has any problem, any disease, and you are going to cure it. Patient has come for the pleasure seeking or from the aesthetic look or from the functional issue. It's no life-threatening problem. So you have to be very, very sure what you are doing. Thank you so much for your patient hearing.
Thank you very much, madam, for the clear talk on clitoral hood reduction. It is really, your pictures were very good. Thank you very much. Now I hand over the podium to Dr. Premlata. Recording in progress.
Yeah, after this wonderful talk on labiaplasty, now we are going to have another lecture on vulval cosmesis. When we say vulval cosmesis, it refers to the technique where the modifying the look and anatomy of the vagina makes the woman look more aesthetic, and she allows for better sexual intimacy. That is what called vulval cosmesis. To talk on vulval cosmesis, we have today Dr. Natasha Vijayendran. She is a fellow hair restoration. She has a fellow in hair restoration. She is a certified injector, and she is a dermatologist, very much interested in hair transplants, aesthetic injector, laser specialist, and metabolic medicine. She is a holistic dermatologist. And she's the founder and head of Trico 360 Hair Clinic, consultant dermatologist, AA Derma Science, and Francisca Hospital. I call upon Dr. Natasha to talk on vulval cosmesis. Over to you, doctor.
Good afternoon, everyone. We've had a couple of lovely lectures by some eminent speakers, and now for the next 15 minutes, I'll be taking you through vulval cosmesis. So when we talk about vulval cosmesis, it basically pertains to everything when we're talking about vulval rejuvenation, as well as how your vulva looks, feels, makes you feel better, and also in return makes your partner feel better, thus not only helping you personally enhance the patient's self-respect, self-confidence, but also their sexual experiences. So what are the most common concerns that we see as doctors and aesthetic practitioners with respect to the vulva. We Indians have known to pigment the most, and hence pigmentation is the most common. You can either have hyper or hypopigmentation. Secondly comes hair. Now, everybody wants to have a hair-free vulva. So hair reduction is something that we will be talking about again today. Stretch marks is the third most common concern that women walk in with, especially in the vulval area. The fourth is vulval rejuvenation. So here we're talking about all the age-related and even pregnancy, delivery-related textural changes, dryness, itching, episiotomy, scars, and how the skin laxity progresses. And the last but not the least, we will be talking very briefly about PRP and fillers, how it helps with vulval or vulval augmentation. When it comes to any cosmetic procedure, like Dr. Ragini ma'am clearly said, that patient selection is very, very important for any cosmetic procedure. So taking an adequate history from the patient, understanding what has the duration been like, what is maybe aggravating the condition or reducing the condition, what has been the stability of the lesion, do they have any pathological concern in that area, are they getting repeated folliculitis, have they been waxing or shaving that has caused skin to become loose, has caused skin to cause pigmentation or any acne in that area. So a clear history and choosing the right patient is actually very crucial here, because what happens with any aesthetic procedure, whether it be something for cosmesis or whether you're treating scars, you're doing a PRP, patient and doctor, expectation and reality being met is extremely important. When we talk about a patient exclusion criteria, again, if there is any active fungal, bacterial, or vaginal infection, then we cannot do a cosmetic procedure on them. If there is any collagen disorder or any topical steroid therapy that has been given, then again, the aesthetic procedure needs to be postponed. Now, what are the common laser systems that we use? Dr. Mala is going to take a very in-depth, session on laser mediums. But just to briefly explain to you all, carbon dioxide laser is one of the most commonly used lasers for the vulval area. The target chromophore being water. The Q-switch Nd:YAG is the second most common because this is the only laser that targets melanin. And then we have other lasers like the diode, the excimer, the erbium YAG, and the IPL laser. So for vulval cosmesis, the carbon dioxide laser, of course, a radio frequency works well as well, and the Q-switch Nd:YAG lasers are the three main laser devices that we use the most. Let's talk a little about pigmentation. Now, 1 in 10 women in India have a pigmented vulval area, and we as Indians, depending on your genetic predisposition, also depending on where you're from in the country, we have a tendency to pigment much more. And as women, the areolar, your genital area, underarms, especially your groin area, back of the neck, these are areas that tend to pigment a little more, and it is seen more in women who come from East India and South India as compared to women who come from the northern aspects of the country. Again, we need to understand, why is that hyperpigmentation happening? Is it just an increased melanin which is happening, or is it because of some other cause? Could it be a vascular lesion? Could it be something that is triggering that pigmentation? So when we talk about pigmentation, we have physiological pigmentation, post-inflammatory hyperpigmentation, acanthosis, frictional, and vulval bleaching that we usually come in to see. Now, when we see pigmentation, how do we differentiate? Is this physiological? Is this frictional? So basically, when we see physiological pigmentation, it will occur in a symmetrical manner. So it will be there on both sides of the vulva. The clitoris may or may not be involved. And usually the tips of the labia minora are enhanced. If it is physiological, also if you notice the other areas, the perianal skin, the underarm area, even on the face, there will be areas of hyperpigmentation. Again, the pigmentation might not be uniform, it might be uniform. So understanding that where there is hair, the pigmentation is going to be deeper, because at the end of it, every hair root contains melanin, which in turn causes pigmentation. Also, the history of any oral contraceptive pills, pregnancy or menopause, again, adolescence, these are ages where the pigmentation does increase considerably. So that needs to be taken into account when you take the history. Post-inflammatory hypo or hyperpigmentation, this usually occurs over a previous injury or a previous dermatosis. Most of the times a patient will give a history of itching or any past fungal infection, or they could just have say that, they got a treatment done in that area that caused the pigmentation. So understanding what is causing and how it is occurring and differentiating these two is very important. For example, post-inflammatory hyperpigmentation responds much better than physiological pigmentation. So accordingly, we can counsel our patients and see. This is a case of acanthosis nigricans. We are all very well known with this term, but the vulva is the third most commonly affected area. And yes, as we know, it is affected with a metabolic syndrome and an insulin resistance. And usually we see that the skin is thick, velvety, dark and warty, and there is sparing of the mucous membranes. And also you will notice that there are other areas involved. So the back of the neck can be checked, the chest area, underarm area, under the eyes can be checked to see whether there are any other areas of pigmentation. Coming to frictional melanosis, if you see, this is usually because of a mechanical rubbing or repeated friction. It could be the patient herself is rubbing that area. It could be the friction due to fragrance condoms. It could be pad use. It could be synthetic panties that have been used. So again, history is very important in treating the underlying pathology, that is using either a corticosteroid cream or an immunomodulating. Treating the melanosis, the frictional aspect of it, and then treating the pigmentation is important. So if you look at this patient, if you see on the left-hand side, you see that the skin is a little thicker and you can make out that something has been happening there, and thus you can take, a history accordingly. So when we treat any type of pigmentation, lifestyle change is very important. So if you're treating acanthosis, treat the underlying disorder, give metformin, treat the insulin resistance. If it is a physiological pigmentation, then we know we can just give an antioxidant. You can maybe add vitamin C, improve the diet, check, is there something like the clothes that I mentioned or condoms or packs that are increasing the friction and pigmentation. So counseling is very important. Various topicals are available. So you can go in for a kojic acid, a glycolic acid, retinoids and azelaic acid work very well. I, however, prefer to stay away from hydroquinone and retinoids in this area until and unless it is something related to acanthosis. Chemical peels work very well. You can also combine this with lasers. So glycolic acid peel is one of the best for pigmentation. You can start with 20 to 35% and then go up to a 50 and 75. Even lactic acids work as a very good exfoliating agents along with TCA peels, which work very well. However, the downtime is a little longer in these cases. When we talk about lasers, as I mentioned, the Q-switch Nd:YAG laser is the laser for choice for any type of pigmentation. It comes in two wavelengths, 532 and 1064. In Indian skin, we use 1064. And there are two handpieces that come with it. So you can either use the zoom or the fractional handpiece, depending on the pigmentation. Typically, one session is done every 2 weeks, and you need to do at least 6 to 8 sessions to see a difference. And this is combined with your topical treatment as well. When we talk about fractional CO2 laser, we know, just briefly explaining what the fractional CO2 does is it's targeting the water in your skin. So it's basically making tiny micro channels into your skin, which gives a deepened thermal effect there. So this thermal effect and the photomechanical effect causes collagen stimulation, which in return improves your skin texture and thickness. So this will not only improve those fine lines and wrinkles, skin laxities, stretch marks, etc., and scars, but this also helps in improving your pigmentation. These are a few before after pictures. So this is a groin area. This was just a frictional pigmentation, which is very, very commonly seen in Indians. And this is just using creams and the Q-switch Nd:YAG laser. This is another patient. Now coming to hair reduction. Hair reduction, actually this picture that I have showed is quite funny because, I actually get in patients saying that they want their hair to be shaped in this particular way. So the recent trends that have been happening, and with social media especially, now the traditional methods of raising and waxing have reduced, and people are going in for laser hair reduction because they are stress-free for a longer period of time. And laser hair reduction also helps in, reducing the hair thickness and also improving your skin texture. So these are the different shapes that we can encounter when we are doing hair reduction. Again, a lot of people ask me that, okay, if the patient cannot go for a laser hair reduction, which is the other method that is good? So shaving and trimming is much better than waxing, contrary to what we have, been brought up thinking that waxing is always better, but no, shaving and threading is much better. In fact, waxing, the fragrance that is there in the wax, that pulling that we do when we remove the wax, all of that causes skin laxity, and maximum laxity is seen in the vulval area. So women who get a bikini wax done are known to show looser skin, thinner skin with more fine lines and wrinkles, and more sensitive skin. Also, pathologically, if you say that if there is any medical indication, if you're going in for a hymenoplasty, if you have recurrent folliculitis in that area or acanthosis, then those are medical indications to get a laser hair reduction done. The common laser systems used are the diode, Nd:YAG, IPL, and alexandrite. The diode is the most safe because it is safer in Indian skin types. However, I feel the latest laser mediums like the triple and quadruple wavelengths show very good results with minimum side effects. So again, with laser hair reduction, anyone can do a laser hair reduction, but understanding the technology, understanding how it needs to be done, how to minimize the side effects, because the burns that happen after a laser hair reduction are permanent and they can be extremely scarring. So we need to avoid that, and evaluation of the patient and counseling the patient is important thus before choosing your patient for laser hair removal. So the most important thing is counseling your patient that it's not going to be a permanent hair reduction. Yes, the frequency at which the hair comes is going to reduce. You're going to have longer hair-free periods. Yes, your hair density is going to reduce by 80 to 90%, but it's not going to be 100% reduction. Also, checking for any hormonal evaluation is very important because those can affect your results. When we talk about sessions, typically we counsel for a 6 to 8 number of sessions for hair reduction and then a maintenance every 6 to 12 months. But if you're someone with, if your patient has a hormonal imbalance and they're going in for hair reduction, then yes, you will need more amount of sessions. Why you should expect your patient or counsel your patient to go in for laser hair reduction is that when you have a hormonal imbalance, it leads to recurrent folliculitis, it leads to thicker skin, more pigmented skin, and having a hair-free canvas is going to reduce all of these three things indirectly, and hence we must think about this aspect as well. So these are just a few pointers when you go in for the procedure. Photographs are important. Mark and shave it. Always patch test it. An anesthetic cream can be used, but newer lasers don't need anesthesia. And the complications, as I mentioned, are very severe. You have redness, burning, blistering, and crusting. Thus, educate your patients that they must do it from a proper doctor's clinic and not from a random salon, because the side effects can be scarring and permanent. Now coming to stretch marks, this is extremely common, whether it be puberty, whether it's pregnancy or just during your lifetime. And counseling your patients and telling them that at the end of it, the stretch mark is a scar. It is completely natural. We all have stretch marks and you cannot completely get rid of stretch marks, but yes, you can improve the appearance of it. So there are different types of stretch marks. As I have listed here, you have ones that are red, then you have white stretch marks, you have ones that occur only in pregnancy. We've noticed a lot of gray and blackish stretch marks of late. Even during pregnancy, you have linea nigra that comes down from your chest to your pubic area. So that is a type of stretch mark, but we don't call it a stretch mark. And then you have atrophic stretch marks that are associated with thinned out skin. Now, family history and ethnicity is very important. So taking proper history, I have noticed that a lot of patients use steroids, unknowingly during their pregnancy on their stomach. It's come as an scar cream or an anti-pigment cream. It always has some steroid in it. And that in turn leads to thinned out skin of the abdomen and the vulval area. And the stretch marks are more inflamed and more difficult to treat. So even when you see your patient during the first trimester, I think counseling the patient properly, explaining to them that moisturizers being used, you can use coconut oil, you can use bio oils, all of these work very well during pregnancy in keeping your skin elastic. And also, yes, yoga, working out, the more elastic your skin is, the more healthy your lifestyle is, the less stretch marks you will have. Coming to the treatment of stretch marks post the delivery, you can opt in for topical retinoids. Microdermabrasion and TCA peels work well. As we discussed, the fractional CO2 laser again is, a gold standard for everything and anything. So it does help with collagen and elastin stimulus, and thus it works for stretch marks. However, again, one session is done 1 to 2 month intervals, and at least 3 to 6 sessions are needed. And explaining to them that it's not going to go 100%, but yes, we can improve it by about 50 to 60%. Carboxy therapy is a newer treatment modality where carbon dioxide gas is injected right below the needle, and the results are phenomenally good. So when we talk about complete vulval rejuvenation, we are identifying these different concerns. We've already spoken about stretch marks. We've already spoken about pigmentation. We also get patients coming in saying that we have loose skin, we have wrinkly skin. The skin is becoming more dry with age, post-menopause especially. There's itching that is there post-menopause. So these are the common aesthetic concerns that you can come with. And, with all aesthetic patients, unlike medical patients, I think a little cradle holding and hand holding is extremely important, and telling them that yes, we can improve it, but we might not be able to completely get rid of it, because this is completely natural, and body positivity is what we are.
3 more minutes, Dr. Natasha.
Yes. So the fractional CO2 works very well. It helps with resurfacing. It will reduce those fine lines and wrinkles. It will make your skin tighter, and it improves the texture. Again, anesthesia, topical anesthesia must be used, and the complications again can be either hypo or hyperpigmentation. So be careful when you're doing it for someone with a skin type 6 or 7. And the best thing is that this can be combined with PRP and other skin lightening cocktail formulas. Micro needling radiofrequency is relatively new. Here we're using tiny needles that go into the skin and deliver serums and also energy there. Thus, again, it's boosting your collagen and elastin, helping you getting tightened and glowed skin. PRP, again, Dr. Sejal will take a very good lecture on this. So it just helps with giving you natural results. Also, the patients are more open towards it because it's their own blood. And there are fewer side effects, less downtime, works exceptionally well on improving the skin texture, fine lines and wrinkles, and also helps with skin tightening. I'm not going to get into the details of the procedure, but the last but not the least is hyaluronic acid, and it works very well, especially in the vulval area. What it does is it binds to water, it absorbs that water, and it plumps up that skin. So it's like a balloon. When you have a balloon without air, it looks dark and crinkly, and the minute you put water inside, the surface is nice, tight, bright. So that's the same logic with hyaluronic acid fillers as well. However, when you do fillers, understanding the regional anatomy is very important, and also the blood supply. There are a lot of skin boosters that are there right now. So these skin moisturizers, which are known as Profhilo or Volite or skin boosters, are tiny injections, just how you give PRP. It's given into the vulval area, and very phenomenal results with it, even better than fractional lasers. So this is a very, very easy procedure to do and exceptionally good results. These are a few pictures of vulval. Here we have not only done skin boosters, but we've also done vulval augmentation, where we've used fillers to enhance the labia. This is another picture. This was after labioplasty and then fractional CO2 laser. So when we talk about vaginal rejuvenation, when we talk about vulval cosmesis, understanding that a basket approach is important with your gynecologist, with the dermatologist, with the nutritionist. Make sure that they're following a good diet and lifestyle and be stress-free. And yes, we can always work towards better and healthier skin, but also understanding that, it's only normal, it's only natural to have wrinkles, fine lines with age. And until and unless that does not bother you and your sexual experience, there's no need to treat it if not needed. Okay, thank you. If there are any questions, you all can ask me too.
Thank you, Dr. Natasha, for the wonderful talk on vulval cosmesis. We Indians, we are all culturally very have inhibitions to talk about vulva rise from childhood. We never think that it is an important structure at all. And we are just always, as gynecologists also, we see many patients when they have a lot of hyperpigmentation on the thighs and over the vulval area. We never even try to find out whether it is bothering her any much. And she may be hesitant to talk to us, and we don't also ask
or any questions about it. Your talk on vulval cosmosis or pigmentation and the hair reduction is really superb and is opened a lot of visitors to the minds of a gynecologist. Thank you, doctor.
Thank you, ma'am. Thank you for having me.
Now I ask Dr. Dhalashmi to take the chair. Dada. Dr. Dhalashmi. Unmute, Dr.
You have to unmute,
Yes,
madam.
yes. That was a mesmerizing session, I would say, Dr. Natasha. Things that we hadn't heard before. It was nice to know that so many things are happening in our own country. We all think that all these procedures were things of Western world. Now, nevertheless, we have another personality coming to give us a very good, interesting lecture on energy-based devices by Dr. Mala. We have heard her some time back in one of our conferences at Ramchandra.
Excuse me, ma'am. Dana madam, Dr. Red Allensood is there, madam. Sir will deliver his talk now.
Okay. I didn't know the order. Thanks. And
so kindly introduce him.
Yeah.
So, sir, Dr. Red Allensood.
Yeah, anyway, waiting for Mala's lecture. I just want to know whether I've understood when she gave about 4 years back. At least if you have understood the principles. As Dr. Red Allensood is going to talk on testosterone pellets, which is forming part of your vaginal regeneration sessions. Let me introduce him.
Madam?
Yeah.
We are happy to invite Dr. Red M. Allensood to deliver his lecture on testosterone pellets in vaginal cosmesis section. And he is completed medical training in Loma Linda University Medical Center in 1990. He's the director and founder of South Coast Urogynecology and Allensood Institute of Aesthetic Vulvovaginal Surgery and Educational Institute. And he has developed so many procedures and to his credit, radiofrequency surgical techniques for aesthetic gynae surgery, in-office technique, in-office radiofrequency labioplasty, in-office vaginoplasty and perineoplasty, medial curvilinear labiomajoroplasty and Thermivo. Thermivo is what I had heard some time back, and O-shot with AM drop amniotic fluid. And he had been awarded several times in the past. In February 2017, he was given outstanding contribution to cosmetic surgery in 2017 International Society of Cosmetic Gynecology, San Diego, California. And in May 2017, he was given an award of lifetime contribution in cosmetic gynecology by the European Society of Aesthetic Gynecology, Madrid, Spain. And in July 2017, he got the Best Feminine Regeneration Enhancement Award by the Aesthetic Show Las Vegas. And in April 2018, he was given an award for outstanding contribution in cosmetic gynecology by the European Society of Aesthetic Gynecology, London. Sir, we are eager to hear you talk on his testosterone pellets as part of vaginal cosmesis session. Over to you, sir. The podium is yours.
So,
thank you very much. Hi, Mala. Hello.
Fine, sir. Thank you. Good evening, sir. Welcome to India. And in fact, good morning to you. So it is nice to have you here, sir. In fact, sir is my mentor in cosmetic gynecology, and he does an excellent training program for cosmetic gynecology, in fact. So it was a real pleasure to have you with us, sir. So I kindly deliver your address. So would you like to say a few words before we play your recorded lecture, sir?
Yes. I just would like to thank you very much for the kind invitation. I miss India. I remember coming there.
So you're muted. So you're muted. Yeah.
Oh, okay. Can you hear me now?
Yes.
Okay. I just wanted to thank you for the invitation. I miss India. I had a wonderful time visiting there at the All India OBGYN conference, approximately 2016. And my goodness, your country has grown tremendously in this field. And I want to congratulate all the leaders in this field. So thank you very much. I just want to go ahead and play the video. This is an everyday practice of mine. I have a very large hormonal medicine practice. It's intimately tied in with my surgical practice. This maintains my surgery patients, and my surgery patients become my hormone patients also. So Mala, you can go ahead. And this is about how I use testosterone in my practice.
We will share your presentation, sir. Chitrakala, can you play sir's video?
Now we'll go and switch to the history of testosterone now and talk about it just a little bit, a couple minutes on testosterone. Dr. Charles Brown Sequard self-injected testicular extracts from animals and reported an increase in energy, muscular strength, stamina, and mental agility. That is the first use that we know of medically. First of all, I want to give credit to a company called BioT that have provided me with some of the slides on testosterone. They're great slides, and I wanted to share them with you. So thank you in advance to BioT. I give a shout out to them. They're a great company that produce a great product that may be something that you can consider for your pellet therapy. They make the pellets for testosterone and also estrogen with the estradiol. So in 1942, testosterone was actually used to prevent peripheral vascular disease. In 53, it was used to help with angina in males and females. And 91% of patients showed an improvement when they used this. In women, testosterone goes back to 1937. It was very effective for treating of vaginal atrophy and other menopausal symptoms. Dr. Greenblatt in 1949 started using it, and it became more routinely used. In the United States, not so much, but in Scandinavian countries overseas, there was a lot of testosterone used, usually in the form of pellets. And these are some of the studies that you can check out if you want to. Despite overwhelming evidence and in support of testosterone supplementation in women, there is still no FDA-approved testosterone product for women. There is one company that makes a pellet that has some kind of FDA clearance, but in general, there is none for women. So here are some facts. Testosterone facts. Women aged 20 to 40 lose half of their testosterone production, and men aged 30 to 70 will lose 1.1 to 3% of their testosterone production every year. You can see here that testosterone is not only in men, but it's very abundant in women. You can see here that there's actually 3 to 4 times more production of testosterone right here than estrogen. An average woman was producing lots of testosterone that would help in their physiologic daily life. And those with a low testosterone in women had issues with their health. It peaks in an average woman. Let me go back here. It peaked in an average woman in their 20s, and symptoms are present both in pre and postmenopausal women if your testosterone was low. You can see here the numbers of testosterone, the values start going downwards as you age. Now, are there studies around regarding testosterone use in women? Well, let's talk about a couple of them. There's a prospective double-blind study, crossover study in women, and it showed that these products here, whether it's estrogen and testosterone alone, or placebo, showed that testosterone was superior for relief of energy, well-being, somatic complaints, and psychological symptoms. Testosterone, not estrogen. That's remarkable. Worst was estrogen alone and placebo. So testosterone actually in this study showed better effects for women. It's no wonder more and more women are taking testosterone either as a cream or a pellet. There are no established lab values for normal and testosterone, and the assays vary all the time, and the levels don't correlate very well with the presence or absence of symptoms. And so you have to use some common sense and experience to manage hormone patients with testosterone. And total levels are not equivalent to free or active hormones. And so we have to take into account the receptors also, whether they're working or not. So here are some myths. We're going to run out of time. I was hoping to present for about an hour. And so let's talk about some of the myths here. Testosterone is a male hormone. Not true. Women make it too. Testosterone's only role in women is for sex drive and libido. Not true. It can help with the bones, muscle mass, and be converted actually to estrogen and help them with their hot flashes, sweats, and chills. Testosterone masculinizes females. Nope. That's only in severe high doses and in certain types of testosterone. It requires 30 times the doses of what's given in an average hormone therapy. Testosterone causes hoarse voice and voice changes. You know what? That's only true if you use non-aromatizable anabolic testosterone type of material, and not with the testosterone that we use in our bioidentical hormone therapy. And also, it doesn't really cause hair loss. The testosterone itself is not what causes the hair loss. And testosterone has adverse effects on the heart. Is that true? Not really. I've shown you earlier that testosterone has actually protective effects on the heart. Does it cause liver damage? Really, there's 3 reported cases of liver cancer, and that was from oral synthetic testosterone, not the pellets. Does testosterone cause overly aggressiveness? Not in the low doses that we use. Testosterone may increase the risk of breast cancer. Nope, it does not. And the safety of testosterone has been established for many, many decades, actually. So those are some of the things. In men, again, I don't treat men, but if you have a low T, these are some of the things that can happen, from Alzheimer's to heart disease to prostate issues, diabetes, and sarcopenia, and which is a loss of muscle mass with aging. For women, these are also the risk of what happens with a low testosterone: Alzheimer's, heart disease, osteoporosis, diabetes, and possibly an increased risk of breast cancer if the testosterone levels are low. There's some studies that show that. So positive effects of testosterone include enhanced libido, helps with the heart protection, lowers cholesterol and bad cholesterol, increases the good cholesterol, increases the energy, and helps you with your sleep. It helps you feel better overall. It helps reduce the body fat, prevention of your food from turning into fat right away, keep you leaner, keep your bones stronger, and help reduce the anxiety and help your fantasy life so you have an interest in sex. It reduces brain fog and memory and helps quite well if you use this one, not the synthetic ones, but you use the testosterone, the same testosterone your body used to make. Now, what about injectable testosterone? Well, there are problems with injectable testosterone because they're synthetic. They're not bioidentical. And sometimes the absorption is time released. They're placed in cottonseed oil. You can get allergies. With the injections, there's an immediate effect, then it goes down, up and down. So you have a roller coaster effect. And the levels of the useful testosterone are less than with pellet therapy. Pellet therapy appears to be the most stable production of testosterone. And some of the testosterone may aromatize, which is a fancy word from the testosterone being made into an estrogen. And so it may have estrogenizing effect, like creation of breast buds and things like that. So men don't like that. And it also has a higher rate of breaking down of blood vessels or blood cells. Now, the testosterone that are synthetic can also increase the clotting and affect the patients because there are more thromboxane 8-2. These are products that can increase your clotting risk. And those who are on synthetic testosterone, there are more of these receptor sites on their platelets. And so it can increase your risk. Now, I found this to be quite helpful. Take a look at the complication that can happen with the pellets. And I'm being specific with BioT. They shared this data with me. And you can see here the complication rates are exceptionally small. In their 1.2 million patients from 2012 to 2019, you can take a look at these complication rates, exceptionally small. The highest one was in males. Sometimes the pellet was extruded or came out 2%, but strokes, 0.0041, breast cancer, 0.02. I mean, really low. These show that these are the testosterone, at least, have been very safe to use for patients. Next thing, some of the advantages of pellet therapy for those of you who are thinking of pellets. there's a steady state of hormones. There's no roller coaster effect. It gives you a steady state. There's about 2 to 4 insertions per year. You have to come in anywhere from 2 to 4 times. It improves your lipids, your insulin sensitivity, and your body composition. And there's no significant weight gain with this, and increases your bone density, reduces the inflammatory markers in your heart. And so it's probably quite protective. No, there's no increase in breast cancer or prostate cancer, no increase in heart attacks, blood clots, or strokes. And so this is a page that you can take a picture of real quickly to show you the differences of oral versus injectable versus transdermal or cream versus pellets. The oral ones, I have many patients on oral. They work very well. It can upset someone's stomach. If you take methyl testosterone, it can hurt your liver. And there's no effective oral testosterone for men or women. And this has to be given regularly because the half-life is very short. And there are pills that have estrogen and progesterone together. The injectable, we already went over that. There are problems with the roller coaster effects. The transdermal, the creams, my practice has a lot of cream patients. It has some irritation of the skin, and some a percentage of women don't absorb the estrogen, and I have to give them pills or go to a pellet, but the majority can tolerate the creams. And there's possible transfer to other. If you're one that puts your hormone cream on your arms and you sleep with your arm over your hubby may have emotional crying and symptoms because of the transfer of estrogen. So you have to watch out. So I would recommend you put it underneath your belly button or your inner thighs. The pellets are more consistent in the way they produce a consistent blood level. There is a little bit of pain with insertion, but we use local anesthetic. It's given in your buttock area, and it's quite fast. It's about 2-minute insertion, and you can change the dosing every few months as you need it. Other stuff to consider, let's talk about the cost of it. Hormone cream is about, on average in the pharmacy, I use $79 a month or $2.63 per day. It has the estradiol, estriol, progesterone, testosterone, and DHEA in it. So it's all in one in this one little cream, and you click this green thing and it spits out a measured dose of hormone that you put then on your underneath your belly button, your inner thigh, or your inner arms. So let's look at the costs of others. Also, the pellets, it's just with the testosterone and estradiol, it's about $500 every 3 or 4 months. Every 3 or 4 months, you'll need replacement of the pellets. Comes out to about $4.17 to about $5.53 per day. That's about the cost of a Starbucks. So you also have to pay for the cost of the progesterone pills, which is covered by most insurances. So before I go, I want to give a little shout out to Dr. Jeffrey Dack. If you want more detailed information, you can get his entire book digitally for free if you go to dr-dach.com. So that's Dr. and then dach.com. But I hope this has been helpful for you. Please feel free to go to our website, send us questions. I'll be happy to answer them.
So this is our typical setup for pellets. We have our gloves, 10 cc's of local anesthetic, an 11 blade, and we have alcohol swabs to clean the area. We have our estradiol and testosterone pellets. For example, this one is 8 milligrams and this is 12 milligrams of a estradiol pellet. On this side we have 37.5 and 87.5 of the testosterone pellets. We have our skin glue and tape, and then a big tape to cover the whole area. We'll show you how that's used. And then we have 4x4s that are sterile, and this is all sterile. We have our introducer needle with a sharp tip. So this goes in here, and they're used together to insert into the buttock. And here's a plunger. Once the pellets are inside the sheath, which I will show you. Then you use the plunger to put it inside the buttock. And here's some pickups that you have to handle the little pellets. We put the pellets in here. So that's an example. We open this up, we put it in here, and then we use the pickups to place it in here. And then we use the trocar to be placed under the skin. So this is a standard pellet tray. All right, we're going to go ahead and start with a pellet placement. The first thing I'm going to do is identify this line right here and then put my pinky on it, and then 4 fingers. And where my 4th finger is where we're going to do our local anesthesia and placement. So here's her anterior superior iliac spine, and so your angle of placement will be towards the ASIS, towards right here. So I'm going to put a little indent on the skin here, and I see my little indent, and then I'm going to clean that area with some alcohol swabs. Oops, let me have another one, please. Okay, after it's all cleaned up, I'm going to grab my local anesthetic. This is a little bit of Marcaine, 10 cc's. I'm going to aim for my ASIS. So right here is where my mark is. I'm going to put a little wheel here. Sorry about this, a little bit of a pinprick. Okay, and the little wheel, you can see that little wheel. That's where you're going to make your incision, and then you aim for the ASIS, and then inject as you come out. I put it in towards the ASIS. I inject as I come out, and I put the whole 10 cc's in there. And after that, I take my 10 blade, and I'm going to get a 4x4 here and keep it under here. Here's a 10 blade, and you make a little incision just big enough to place your trocar. And after that, you grab your trocar. Here's my trocar. You can see it has a sharp tip, and you can just put a little pressure on this right now. It's great to have an assistant who can help you while you're placing your equipment already. This goes inside of this, and this is what goes in. Okay, I got it. And you aim it towards the ASIS, and then you give it a little pressure, little twistings, and then when it's in, you take out this and you grab your pellet. This is testosterone. You can bring it up here closer so that if you drop the pellet, it's captured. So there's the first pellet. I'm sliding it in, and this patient's getting 150 milligrams of testosterone only, no estradiol. After that, you place the plunger. This is the one with a flat tip. The flat tip goes in here. You push it in, and you pull the whole thing out, and you're finished. See, you see how that plunger works? It pushes the pellet in. After that, we place this skin glue on the patient. Skin glue up here, skin glue down here. After that, we place this little tape and 4x4 that's folded, put pressure on it, and then I have my patient stay still. I place this tape over it, clear tape, and I remove this paper on the edges, and then I press it and hold it. I usually like holding it for approximately 30 to 60 seconds to just take care of the little oozing that occurs. If they're oozing more, then just hold it for a couple minutes. But typically, that's all it'll be. If you have a little red dot there from the bleeding, you can put another 4x4, but I'll just hold pressure here for a little while, and then we're done. All right, so I've placed about a minute of pressure on this area, and I replaced the bandage, and let's take a look. That's how it should look. No bleeding, the tape is well placed, and we'll leave this on. We'll ask her to leave it on for 2 or 3 days, and then she can pull it off. The steri strip that's on there will just fall off within the week, and then she can start normal activity. So we tell them to take it easy for a couple days, and then after, probably, I like to be conservative, in a week they can start doing all the normal stuff. Thank you.
So thank you so much, sir. That was excellent. In fact, you have always some innovative idea. Dr. Sejal also is there with me. I'm sure she'll also agree. So for the benefit of the audience, in fact, Dr. Red Allison is the founder and inventor of the radio frequency Thermiva. Way back in 2016, he first introduced Thermiva to our country in AICOG. And but then after that, we have been wanting to call him, but because of this pandemic, we are not able to invite you live. So we are just waiting for a opportunity to invite you physically to India, sir. So in fact, I always think that you have such an innovative brain. You have so much of ideas. In fact, this is something really new to us. So testosterone, in fact, we have never thought it can be used as a pellet for a female. Maybe we have heard of testosterone gel. Even in IVF, we kind of use it in little bit cases. But then for a postmenopausal women, testosterone pellet is something relatively new. But I just have a query, sir, about this. How do you exactly remove this pellet after the insertion? After maybe 3 months or so, you have to keep removing it, or?
Can you hear me?
Yeah, we can hear you.
The pellets will dissolve and you never have to remove them, except for the rare occasion that they come out near the opening and then you have to remove them. That's like for men 2%, for women less than 1% expulsion rate. But these are slowly absorbed and are left in from anywhere from 3 to 4 months. And then you come back in every 3 to 4 months and put the next pellet in after blood test. So your dosing is based on blood levels, and you punch it into a computer and it tells you how much estradiol and how much testosterone to implant. There's various doses. And so you have to go by patient symptoms and the blood test for the dosing.
Okay, so ideal value of testosterone for which we can use it as a pellet? What is the ideal value? Normal value.
For women, it's between anywhere from, they like it to be between, for example, 150 to 250. I forget the values, but we go by 150 to 250 typically. And it's higher. It's basically almost double of the top end of the lab values that are considered normal. So you want to keep your patients on the very top end, if not double of the top end values. And if you use natural testosterone and not the synthetics, those will be converted to the safe kind of estrogens. And so there's a whole program to teach this. It's a 1 to 2 day program that the company sends you to Dallas, Texas, an intense training, hands-on training for those who are interested. And it will transform your practice, especially in your country. It's not so prevalent yet. I have colleagues who make this 100% of their practice, and they're making millions here in the United States on hormone practices alone, and not even doing surgery anymore. I have a vascular surgery friend who does nothing but pellets, and he's making over $1 million a year on pellets. It's crazy.
Is it FDA approved? Is it?
It's a pellet, so it's outside FDA purview because it's compounded by the pharmacy.
Okay. So what is the indication that you use pellets for?
Perimenopausal symptoms, menopausal symptoms.
Reduce libido?
Yes, for low libido, those who want to keep osteoporosis reduced. So everything that you use standard estrogen progesterone for, those are the indications. So mostly perimenopausal, menopausal, and many of your young patients in their 20s and 30s who are not menopausal at all, many women we give testosterone to for libido, physical strength, keeping them lean so that even when they exercise, they stay lean. And it gives them a good sense of well-being, and it keeps them interested in sexual activities. So the young woman, many are supplemented with testosterone either as a pellet or a cream, and you have to follow them with laboratory work every few months.
Okay. So any absolute contraindications for this?
Contraindication, probably any hormone responsive tumors, if they've had it. This does not increase your risk of breast cancer or any of those. Also, perhaps you don't want to use it for those people with already very high testosterone. For example, it's difficult for polycystic ovary patients to use this. Usually we just give estradiol, and not the testosterone, but there's very few contraindications to this.
Okay. Okay, thank you so much, sir. It was really.
You're very welcome. It's a pleasure to see you. I hope I get to visit India again. It's one of the best places I've come to, and the doctors are so brilliant and so responsive and so appreciative. And so I just love my doctors who have come to visit me from India, like you and Sejal and a couple others. So it's a pleasure to be with all of you, and I hope to visit you again someday.
Yes, we are looking forward for the day. So we'll invite you very soon once the thing settles down here.
I'll be there.
Yeah. So after this talk on elixir of youth, testosterone pellets, we move on to the next talk, aging and cosmetic enhancement of skin. We know that aging brings about a lot of changes on the whole of the body, and especially the most visible thing changes are the skin. So I think no, the CV has been changed. Now Dr. Annie Flora is going to speak. That is what I was told. Okay. So to talk on this aging and cosmetic enhancement of skin, we have Dr. Annie Flora, who is a UG alumnus of Tanjavur Medical College and PG alumnus of Madras Medical College. She is the Honorary Secretary of IADBL Tamil Nadu and consultant at Apollo Cosmetics VS Hospital and MD at Ray and Rio Specialty Clinic, Chennai. She is an invited speaker in various in state and regional conferences and workshop organizer for aesthetics and trainer for Botox, fillers, PRP and chemical peels. So Dr. Annie Flora, please. Dr. Annie?
I hope I'm visible. Am I audible, ma'am?
Yeah.
Okay. I would like to thank Chennai Menopause Society for giving me this opportunity. So, is my screen visible?
Not yet.
Just a second.
Yeah, full screen, please.
Yes, ma'am.
Yeah. Seen well.
So thank you, Dr. Hepzibah, Dr. Shanti, and Dr. Malaraj for having me here today. Anti-aging in dermatology is a huge field of which I can only give you a glimpse into what we do. I cannot be elaborating on any particular technique because it will be an injustice to the rest of the procedures. So let me go straight to the topic. Why is age just a number? Those days, people were willing to age gracefully. I'm sorry for bringing in cine personalities here. I will end with this. So it was okay to age like this. But these days, the demand has grown so much that we cannot afford to age like this. So everyone prefers to be this way. How she is today, she does have still some more remaining things. This is a realistic expectation which we can deliver with anti-aging treatments as of now. So why is it important? And when do we age? We all start aging when we stop growing. So it starts from, let us say, 20, 25, and then it actually starts being visibly seen right from 30. But from 40 is when people start appreciating the aging changes on their skin. So then what do? They start taking desperate measures to try to look younger. So when do we need to start? We need to start as soon as we are aware. And this growing demand has led to a vast array of treatment options. We will be seeing them one by one. How is skin important? Skin is the largest organ. It is not just an organ, it is the organ of protection. It protects the rest of the body from the environment. It also has hormonal features. It does vitamin synthesis. It excretes unwanted waste material. It's also a medium through which materials can enter into your body. How we use skin patches, how we all our ointments, creams, everything is based on this. Skin plays a very important role for thermoregulation, and it is the interface. And right now it is psyching people so much that they want to look the way they want. It's not how they look. Now it is becoming more and more tailor-made according to everybody's requirement. So where all does aging happen? We always look at the skin. Is it just at the skin level? The skin is composed of epidermis and the dermis. On the epidermal level, what we see fine lines, we see pigmentation. We also see skin growths like DPNs, we see seborrheic keratosis. This is on the epidermal level. Then coming to the dermal level, the subcutaneous level, the superficial musculoaponeurotic system and the deep subcutaneous fat, the muscles and the bone. So aging happens everywhere. Only when we know all this, we will be able to address it better. So it is an interplay of all these things. Biological factors comprises intrinsic aging. We age how our parents age. It is genetic how we age. And it is said that male age more than female. Estrogens give a little amount of protection compared to the testosterone. That is why menopause is associated with more aging changes. About the intrinsic, coming to the extrinsic factors, we have sun. Sun is the most important cause for aging, because when we see farmers going out in the field, we see how much of aging lines happens on their skin. And based on the weather, like we stay in a tropical climate, more outdoors, more aging. Pollution, people those in the city age more than those people who are in a healthier environment. And about our lifestyle, exercise and healthy well-being is very important for maintaining a youthful toned look on the face. And our nutrition has an important role, because when we eat healthy, we look healthy. And when your nutrition includes a lot of junk food, there's more amount of alcohol and other additive agents, unwanted agents into the system, it starts showing on the skin as well. And smoking, definitely a negative factor. And when we think of sleep, a proper 7 hours sleep is a must if we need to have a good looking skin, because you can see dark circles coming up, which is a part of all these changes, which our sleep pattern also shows. Emotional well-being, yes, when we are stressed, our skin shows it. Beauty and routine is a very important part, because this Cosmesis includes, it is not complete without the skincare products which they use. So initially, when we are younger, we have this inverted triangle appearance on the face, but as we age older, we lose a lot of things on our skin, and thereby gravity starts playing a part and the triangle gets straight. So now everything goes from the upper face to the lower face. So once we know this, we know what all to correct, where all to correct. So coming to the dermal area, the epidermis starts showing. When we think of the dermis, we should understand that photoaging also causes this. Hyaluronic acid, elastin, collagen. This is a prime area where we are going to do a lot of range of treatments. So this goes off with age. Our skin starts dissolving it, but the reformation is not as adequate as it is being lost. Another thing which we lose, we tend to lose fat from the cheek area and the entire zone. The skin starts drooping down. Coming to the muscular area beneath it, what happens in the muscles when there's overactivity of the muscles? We can see lines forming exactly perpendicular to the direction of the muscles. So this is how our lines form on the face. This is just an example of what happens. These lines, we call them as dynamic wrinkles, because this is formed by the action of the muscles underneath the skin. Why it is important? Because we go along the direction in between the lines. That is where we target with our treatments. After the muscles, it is the bones. You can see in a younger individual, in an older individual, the hollowness, the temporal hollowness, the cheek, the zygomatic bone, everything starts resorbing, resulting in the contour of the face being lost, the denture being lost, the dentition being lost. So all this plays a role in changing the appearance of the skin. So this is about the bone, and now we know all the different layers. This is a gist, this is not the details. So now we understand where everything went wrong and this has changed. In addition, we have something called like pigmentation, lentigines, freckles also, which are a part of the aging change. And these are growths on the skin which we see. This is a seborrheic keratosis, which is very common. Literally everybody in our OPD tends to come with this. So coming to anti-aging, what all can we do now? Since we know this, unless we do a lifestyle change, like if there's smoking and alcohol, it has to be stopped. And we move to a skincare routine. If we use soap or harsh body washes on the skin, we are going to cause more damage. More damage means more aging skin. And if we are going out without sun protection, we are letting the UVA rays, which are the aging rays, hamper our skin, resulting in more amount of wrinkles. So it's very essential that we follow good sun protection. Moisturizing twice or thrice a day and up to bedtime. It's essential to prevent further damage, create a layer of protection so that the skin is able to have a soothing environment so that it gets rest. Then coming to the anti-aging creams, which is everybody's favorite. Everybody wants some anti-aging cream, but based on the skin type, based on the skin's requirement, the anti-aging creams may need anything from an AHA, BHA, retinols, lightening agents. We may need anti-inflammatory agents. We may need free radical scavenging creams, and we may need a lot of nourishers as well. And now sunscreens and moisturizers have gone from topical applications to oral intake as well. We do have oral moisturizers, we have oral sunscreens, we have collagen, we have glutathione, everything oral. And this is like anybody can move into this range. But once we move from this into the procedural range, the indication is that anyone who wants to look younger and fresher can go with these procedures. However, the contraindications are for the physician's end. If there's an uncontrolled diabetes or a systemic illness or any infective etiology as well, or cancerous conditions, we try to avoid these treatments for such kind of patients. There are bleeding disorders. Body dysmorphic syndrome is something we have to keep in mind when we listen to the patient itself before suggesting any procedure for them. And unrealistic expectation, definitely a no-no. So starting with collagen inducers, the aim is to increase the dermal thickness. It works very good in the periorbital area and for fine lines across the entire face. The common one is fractional resurfacing. How it works? Columns of laser ablate the existing skin. They help in neocollagenogenesis. Their only disadvantage is that there is a downtime and it doesn't suit Indian skin because there's going to be a lot of pigmentation following a fractional laser skin resurfacing. It's because of our aftercare as well as because of the environment. So now we have another option called as, okay, here you can see what kind of result we can expect. This is not my patient, but this is the kind of result which we can get with fractional CO2. But because of the amount of pigmentary changes it does, we have now moved into microneedling radiofrequency. This is again energy based. Here what happens, needles go under the skin and they deliver the radiofrequency energy underneath, causing collagen shrinkage. So there will be a turnover of collagen resulting in more new collagen. The advantage is that this has a lesser downtime. Platelet-rich plasma, I hope Dr. Sejal, it's her cup of tea for you to, on the gynecological aspect. Here we also do it. Where all we use it, the advantage is that it is autologous and it can be given as intradermal injections. The main crux of PRP is how it is prepared. If we are going to fail on the preparation method, it's going to be a failed PRP, failed results. And we depend on PRP because it is it's like a ball of growth factors directly put at the spot where it is needed. On the skin, we use it for open pores, fine lines, stretch marks, for the hair, for hair fall, etc. So after the dermal layer, we move into the SMAS or the superficial musculoaponeurotic system. So for rejuvenating this, we use radiofrequency energy, which is delivered directly to the dermal, subdermal levels, causing collagen tightening. The results can be seen after like a few sessions done at 2 weekly intervals. And this is how we can expect a change. Like it doesn't give 100% change, but it gives anywhere between 30 to 40% change in the texture of the skin and the tightness. My favorite is HIFU. I do it for anybody who wants any little amount of tightening also because the results are instantaneous. On the table it is done and the patient, when they get down, they can see the difference in the tight. They can feel the difference on the, especially the lower face, because every HIFU probe delivers energy at a particular depth. 3 mm, 1.54, 4.5, 8, 13, etc. Where all it works in reducing sagging of the face. It works in double chin. It helps lift the brows. And the higher version of it is called Altera. So this kind of result we are really able to achieve with our patients. A couple of sessions or 3 sessions give such results, and the results stay for 1.5 to 2 years also. Next layer beneath it is the muscle layer. And for relaxing the muscles, we use botulinum toxin. And how it works, at the neuromuscular junction, acetylcholine release is inhibited because it targets the snare proteins which help in release. And once botulinum toxin reaches there, there's no more release, thereby the muscles no more act. It causes a flaccid paralysis. But dosing is very important for botulinum toxin. So you can see how it breaks the snare protein, so there's no more release. This is the kind of result we achieve with botulinum toxin for the crow's feet, for the forehead lines, for the frown lines. We also use it for people who have square jaw because of masseter hypertrophy to get them an oval-looking face. And you can see how it corrects the frown lines. This much of correction cannot be achieved with radiofrequency of hypo, but it is only botulinum toxin which can do it. The only disadvantage is that it stays only for 4 months, 4 to 6 months for some patients, after which we have to redo it. Botulinum toxin, I also use it for hyperhidrosis of the palms, underarms, for feet. The side effects, this is pocking. This is something which nobody wants. You know, the eyebrows are spocked. This is an unnatural appearance, which happens if the injections are given at the wrong locations. And sometimes if it drips down, then we are going to also have brotosis, lidtosis. And in the depressor anguli oris, if Botox is given overdose, it is going to affect the other muscles as well and cause this kind of effect. Here you can see a lidtosis if it is done wrong. So that is about botulinum toxin. Now we go to fillers. This is nothing but hyaluronic acid. Where it works wherever we can fill a hollowness or accentuate a feature which our client wants. And there are different kinds of dermal fillers. And not all of them are put at the dermal level. It's not everything intradermal level. We go deeper also. We go supraperiosteal also. The permanent fillers are no more used because of the side effects, because of granuloma formation, and because if the patient doesn't want it, then it becomes permanent and they have to live with it, or we have to do a surgical removal of it. Semi-permanent ones are the most popular and they are the most safest. They have a high amount of safety and efficacy profile across the world. Millions have used it. Fat fill I do not do because it's very, very unpredictable. It stays for a couple of weeks for some, 6 months for some, max. So semi-permanent fillers, hyaluronic acid fillers, they also come in a range of 6 varieties at least, and they vary based on their G' and the cross-linking. Where they can be used, they can be used to replace the fat wherever there is fat loss, like the temporal hollowness, the cheek hollowness, the lip, wherever the lip is not adequate, or if they have rhytids, if they have laugh lines, the nasolabial lines, chin augmentation, jawline prominence, name it and you have it. But the variety of filler for each area is different. And the tear trough, this is one of the most common areas where people ask for, and their life varies from 6 months to 2 years based on the kind of product we use. The advantage is that since it looks like our own hyaluronic acid, there's no reaction, there's no rejection, and it can be dissolved if the outcome is not as expected. So here you can see that the nasolabial is prominent, but when a cheek filler is done, the nasolabial prominence disappears. So the pull, the tightness, once that is done, we are able to see a difference in the nasolabial line. This is how it is done nowadays. It is not the previous older days when we used to fill the olden days, we used to fill the nasolabial straight and then make it disappear. When people don't want, they feel that, you know, the cheek has fallen, we fill it here and we push it back. But now we fill it here and we pull it up so that this line, this prominence reduces, as well as they get a good hydration of the cheek, glow to the face, as well as the contour is obtained. So tear trough is one common thing. It's not just for aging people. Anybody from 18 who has a sunken eye look, who has dark circles, when they take a tear trough rejuvenation with a filler, it gives lightening of the periorbital area, as well as it gives a refreshed look to them. Complications, yes, fillers when put in the wrong plane can cause, and since it's a vascular zone, bruise tends to happen, but not very common. But bruise, once it happens, we have measures to take it away as well, and it's a temporary one. Tyndall effect happens when the filler is not put in the right plane. It causes a translucent appearance on the skin. Blindness if it goes intravascular, which is something which we learn with experience that we go the safer way. Very rarely, very, very rarely, there can be a reaction to the filler. Coming to the last one, thread lifts. Why I put it last? Because this is not just one treatment. This goes along with the other treatments. the cog threads with their cog, which has an anchoring effect, will be able to lift the skin. So it is put under the skin, like between the dermis and the subcutaneous, and it is used to lift the skin, and the results can be seen instantaneously. And the results last anywhere between 3 months to 6 months, even though the companies guarantee up to 2 years, but 3 to 6 months is what I see in my in my practice. Monothreads are for collagen synthesis, which can be used as a mattress on the skin wherever we want, open pore tightening, scar reduction, everything. It also corrects double chin, it gives brow lift, and it corrects the cheek sag. Thread lifts are not a primary corrector. They have to be used along with the other treatments to complete the lift that we want. The side effect is that it wears out too soon, and it is not suited if there's too much sag. We cannot pull everything with just a few threads. And if the patient's selection doesn't tally with their expectation, then threads are going to be a real, downer. And dimpling can happen with cog threads, but that is a temporary effect, and it goes off in 2 weeks. Bruising, bleeding, with any of these injections, bruising and bleed can happen, which has to be handled, and patient comes out of it in 2 weeks. So to summarize, anti-aging needs dedication both on the patient side and the doctor side, because as aging is an ongoing process, anti-aging is also an ongoing process. It starts from the day when we become aware of the need. Lifestyle modifications go a long way. It is not just treatment, injection, laser treatment like that. Patients also have to modify their own lifestyle. And the treatment depends on the age of the patient, the intensity of the aging change, as well as on the affordability of the patient. And generally, combinations of treatments are done to achieve the desired results. Thank you.
Thank you, Dr. Annie Flora, for having given us a good insight into anti-aging measures. Thank you very much. Now I hand the podium to Dr. Premlata.
After the wonderful talk on cosmetic enhancement of the skin, now we move on to the next topic, energy-based devices by Dr. Mala Raj. And I don't think the podium needs any introduction. People need introduction of Dr. Mala Raj. She's a very dedicated, and she's a very gynecologist, endoscopic surgeon, and she's interested in cosmetic aesthetic gynecology. Mala's CV.
Can I share my presentation?
Yeah, now she has had training under Dr.
Here is my view.
Yeah, she's the founder secretary of the IAGE. She has the Best Doctor Award from Tamil Nadu MGR University. She has operative faculty in various conferences. She has been authored many chapters in various textbooks. She's the past secretary of IMS. Foxy and ICUG recognized training center for, she is having a training center for endoscopy, trained in aesthetic gynecology under Dr. Red Allen Sud, California. Over to Dr. Mala.
Thank you so much, Madam, for the warm introduction. At the outset, I would like to thank Dr. Hepzibah, Madam, and the Chennai Menopause Society for giving me this wonderful opportunity. So with due respect to my mentor, whom you heard, Professor Red Allen Sud, I would like to start the presentation on energy-based devices for vaginal rejuvenation. Well, in the first half of the 20th century, the vagina was only considered as an organ for reproduction. However, in 1950s, if you see, the importance of the anterior vagina for sexual function and orgasm was also understood. Now, this realization was attributed to Ernst Grafenberg, who identified the G-spot. So if you see, even in our Hindu mythology, Kama Sutra and Jayamangala scripts, they also seem to be describing the same. So women these days are looking for an ideal genitalia. So this is mainly because of the reduced sexual quality of life. They also feel a low self-esteem, and also all this ultimately resulting in marital disharmony. So as a reason, if you see in cosmetic gynecology in USA is almost 20% of all the gynecological surgeries. So women in these two ends of the spectrum, that is women who have completed the family, who have finished their reproduction, the pregnancies, they are the one now who are really looking for all these things because they are ready to take charge of their life and want to get back to shape. And other end of the spectrum are the menopausal and the postmenopausal women who are now suffering with the aging and the declining of the hormones and really want to help themselves up when they have all the resources and also the time to take care of themselves now. So these two end of a group of women are the one who are really looking for all these things. And as we all know earlier, it was really considered as a taboo to even to talk about sexual dysfunction and any kind of intimate problems in women. So because they find it very hesitant to discuss it with a physician and also the treating gynecologist, and the social norms and the attitude are quite not possible for them to come in open and discuss them in the public, and also they kept all these closed doors. So if you see in the physician's armamentarium, the treatment was only comprehensive, wherein they can be offered only a hormonal therapy or some kind of a Kegel exercises and some creams or lubricants, or if at the end of the spectrum, you have to go under the knife, and it is quite an invasive procedure, which not many women were ready to go through. So as a boon came in these non-invasive procedures, which could help them to get back to their normalcy in life, called the non-invasive tightening of the vagina or the non-invasive vaginal rejuvenation procedures. So why? Because it has been found that the vagina's texture is almost equal to that of the skin. So that is the reason our aesthetic colleagues, the cosmetologists who are using the energy sources for tightening the skin on the face, the same principle now is being applied to that of the vagina, because the moisture in the vagina is very good, similar to that of the skin. That is the reason it works very well there. So also we need to understand the character of the vaginal tissue is similar to that of the skin, making this a very obvious candidate for this treatment. And radiofrequency is effective only on moist and well hydrated tissues. And histological studies on the sheep have also proven this. So how exactly vagina is different is that it has a superficial layer of non-keratinized squamous epithelium, which has a high water content, and a deeper layer of the vaginal wall. They contain dense connective tissues, smooth muscles, collagen, and elastin, which gives the vaginal wall the strength and elasticity. So however, with age, they lose their rugosity, and also the decreased collagen and the elastin lead to the laxity of the vagina. The blood flow and the secretions in the vagina also get compromised because of the waning estrogen, and the postmenopausal vaginal mucosa differs, however, from that of the premenopausal because they have a low water content. So as a result, we need to really think whether these modalities would really work, especially the lasers, but then the radio frequencies have been found to be quite effective. So when a woman comes with all these issues, these are the few questionnaires we kind of ask the women to find out what exactly is the real issue. First, a basic counseling is very, very mandatory when such treatments are being offered. So we have major two-based energy-based devices. Of course, there are many more. Like main things are the radio frequency and the laser devices, but there are many variants of these radio frequency and laser as well. And majority of these devices have been offered to patients who do not have any major pelvic organ prolapse. So the ideal selection of the patient is very, very important when you are offering these therapies. So when it comes to the radio frequency, we can either have a monopolar or the bipolar, and they also come either with the cooling or the non-cooling probe. The earlier ones used to come with a cooling probe because they did not have a temperature control, but the current one is the temperature controlled radio frequency that is called the Thermiva. We were fortunate to have the founder of this Thermiva, Dr. Red Allen Soot, and you all heard to him right now, and that was his brainchild, the Thermiva, the radio frequency, which was also introduced by him into our country. Now, how it really works is that the heat is generated in the proximity to the electrode through impedance as the radio frequency energy travels through the tissue, which can be calculated using an equation accounting for the local electrical conductivity and the level of the current generated near the electrode. So this specific pattern of thermogenesis is thus predictable and it can be controlled by the modulating power to the electrode itself. So now therapeutically relevant heating of the tissue has been shown to occur at a temperature of about 40 to 45 degrees centigrade. And this kind of produces its effect on the target organ wherein it increases the collagen and the elastin, stimulate neocollagenesis, and also prevent any kind of a collateral damage to the skin. So this radio frequency energies, therefore, should be controlled in relation to the tissue temperature during therapy. So we have a better control on the temperature, and the patients are also able to respond to us whether the temperature is quite optimum for them. And if it is very high, we can also reduce the temperature while doing the procedures. So this is how the probe looks like. It's something like our index finger. So it does not harm or hurt the patient while she is undergoing the therapy. So this is a problem with the age and the gravity, the waning of the hormones, and how the genitalia looks with age. And we have a solution with radio frequency, the Thermiva. So this can be also used in various other conditions, and we are now using it for the vaginal rejuvenation procedures. But then one needs to understand that it is only effective when the relaxation of the vagina is quite small. So if you are going to have a very large relaxed vaginal introitus, then you may have to only go in for a surgical rejuvenating procedure. So now the characteristic of this radio frequency is that it is a monopolar current. So we need to ensure that we have a dithermal plate which gets the current back to the unit, and it has a thermistor thermocouple for the delivering the current. And it is able to monitor the tissue temperature real time, meaning the patient are able to appreciate how much of heat they can tolerate, and we can adjust the dosage according to them. And we can also maintain the temperature at that particular level for a sustained period for the collagenesis to occur. And it is quite comfortable for the patient, and the software is quite intelligent to predict all of this. So the effects are quite immediate. It causes tightening of the skin, and also causes new collagen and elastin formation, which is basically the major crux over that of other energy sources. The new angiogenesis formation occurs, and most importantly, apart from the collagen and the elastin, it improves the sensitivity of the nerves. That is where it holds over that of the other energy sources. So basically, it is all about the study of science of heat. So all our colleagues using this for various uses, like our aesthetic colleagues also using it for the skin at 42 degrees centigrade, which is also utilized by us for the vagina up to 45 degrees centigrade. And then for the shrinking of the fibrous rectum for our surgical procedures, when we are using the laser, it is about 55 to 65. And our plastic surgeon colleagues are using it at 70 degrees, and the neurologists are using at 85 degrees. So the Thermiva watt or the radio frequency watt we use is at a very minimum temperature of about 45 degrees centigrade only. It is not like other higher temperature issues. So as a result, the damage to the skin and also the collateral damage is very, very less. So here, this is how exactly if you use it on a menopausal women, that is when the vagina are dry without any kind of secretions and reduced blood flow, this causes the dilatation of the blood vessels and the release of the neuropeptides. And as a result, you can see there are quite a lot of secretions happening in the vagina. The blood flow is also improved, so the women feels really nice and well lubricated. And as a result, her discomfort of dryness of the vagina, the itching and pain during coitus, all that comes down drastically. So this is the entire complex of the clitoral which we need to treat also along with this procedure, because it has been found that this small little portion has got almost 8,000 nerve branches, and it also helps to increase the blood flow. So the importance of collagen cannot be overemphasized, because here this is the one which we are targeting. So we need to make sure that the collagens are built by sending across these energy sources, because they are the tensile strength and they are the ones which gives the integrity to the tissues. So this extracellular matrix will have this collagen, and if you see in the prolapsed uterus, it is this which is deficient, which is causing the uterus to prolapse. Exactly the same thing is happening to our skin. The skin has all the three types of collagen, And when they are deficient in this, it causes flattening of the tissues. So the collagen 5 is a very important component of the basement membrane, and we try to build up this collagen, especially the type 1 collagen is what is being built up, and it has been found that they are quite strong and they are as strong as steel. So here you can see how the collagens are intrinsically packed, and with the treatment they improve, and the blood flow also improves. Thanks to Professor Alan Sood for sharing these pictures from his library, and also the dramatic changes you can see before and after the procedure, how the introitus and the vulva looks after the Thermima procedure. So what does the evidence say? Of course, we have now quite a lot of studies which have really come up, and quite a lot of advancement has taken place in this particular specialty, and various studies have proved that these kind of energy sources does give improvement to a woman with a lax introitus, and these are a few landmark studies which have proved that these energy sources are quite efficient. This is by our Red Alan Sood, who has also demonstrated that women who lack their sexual satisfaction score and also the vaginal laxity score do benefit from this kind of the vaginal rejuvenation procedures, and they also sometimes quite effective in case of overactive bladder as well. So histologically also these effects have been shown in these study by Lebenshaw, where they have taken a biopsy from the vulva and the vagina, and these histology shows that there is an increase in the maturation of the cells and also the growth of the stroma after the therapy compared to prior to the treatment. You can see the pre and the post treatment biopsy, and also the collagen development also in the post histology has also been demonstrated, and of course the improvement in the blood flow. And finally, as mentioned, the nerves plays a very major factor which can also be developed with these energy sources. So these are the histological pictures which also shows that there is an irrefutable increase in the small nerve fiber densities after this therapy with these energy sources, and as we are treating the entire complex. So this is a small video of the Thermima procedures. Here you can see how it is being utilized. It is a small little electrode, the probe, which is as sleek as our index finger, thanks to Professor Alan Sood. So this was given to me during my training in California. The video, with his permission, I have utilized. So here you can see how the Thermima is being utilized. You can just a gentle massage action. The patient is awake. It is a coffee break procedure which would take only just 20 minutes for her to come and get it done. For working women, during the coffee break, they can just come down, get the procedure done. In 20 minutes, the entire procedure is over. There is no admission, no pain, no injection, no anesthesia. So you tend to treat all the quadrants, and you can feel that the vagina getting really tightened, and the women can see the difference at the end of the procedure, and she can carry on the normal activities. Now, another energy source which can be used in case of these vaginal laxity is the laser. Of course, radio frequency and the laser are the ones which are currently being used for all these rejuvenation procedures, and there are various lasers also available. And histologically, lasers also have been found to be quite beneficial. They also again initiate an inflammatory and wound healing pathway in the skin, which stimulates the underlying tissues to heal. But only thing is, the laser requires quite a lot of water content. So that is the reason I prefer the radio frequency energy source. And moreover, the probes are quite huge and big, which will not be that very comfortable to the patient compared to our radio frequency, which is very sleek and slender, and the women does not have any kind of a discomfort. So histologic changes have also been demonstrated after the use of the laser, wherein they have demonstrated that there is development thickening of the tissues and also the development of the collagen. So to conclude, the new prevention, the treatment and the management strategies are continuously being explored to elevate the medical and aesthetic concerns in the women regarding the genital area, and the emergence of these energy sources enable the women and their physician to have another treatment in their armamentarium. So in the hands of a well-trained physician, these energy-based devices are likely to benefit millions of women by aiding them in reclaiming, relishing, and also reveling in their femininity at full capacity. So thank you so much for your patient listening.
Thank you, Dr. Mala, for your wonderful talk on energy sources in vaginal rejuvenation. And as you have told clearly how the radiofrequency device increases the collagen content and the elastin and improves the vascularity, nerve supply. I mean, improvement in all this causes increased sexual satisfaction and aesthetic. It was a wonderful talk, and thank you for.
Thank you so much, madam. Thank you.
Good evening, everyone. It's my pride and privilege to introduce Dr. Sejal Ajmera, the last speaker of today's vaginal cosmesis session. She's a founder of the Indian Academy of Vaginal Aesthetics, a fellowship in advanced master's surgical preceptorship in aesthetic vulvovaginal surgery from Los Angeles, and cosmetic gynecology cadaveric course, International Society Cosmetogynec in 2019. And she also had a fellowship in endoscopy from Singapore, a fellowship in IVF. It's a kind of matching with Dr. Mala's diploma in endoscopy, Germany, international teacher, speaker, operating faculty for various aesthetic workshops. Has got many awards, medals, and best speaker and best gynec award in 2011. Featured in Forbes India, which is a prestigious thing, should I say, madam, BBC and London, and consultant at Juhu, Santa Cruz, Surya Hospitals, Mumbai. And also she has crossed the borders to go give a consultation at NMC hospitals in Dubai. Over to you, madam. We're waiting to hear you.
Thank you so much. Thank you for this very kind introduction. And thank you so much, Chennai Menopause Society, for inviting me. It's my absolute proud privilege. Thank you, Dr. Mala. I think it's because of you that I'm here. And I'm so honored that I'm on the same page with you and Dr. Red. What I was trying to say was that he's undoubtedly the ultimate authority in aesthetic gynecology. Apart from being a phenomenal inventor, he's a great teacher, and that's why Mala and me are probably here today, and such a wonderful human being. So thank you very much for giving me this opportunity. I'm going to share my screen so that we can talk about PRP for genital rejuvenation. So let's go on. Well, I run the Indian Academy of Vaginal Aesthetics. It's a dedicated vaginal aesthetics center, and invite all of you all, at any time you would like to visit our center, it would be my privilege. So as we've been discussing, the demands of aesthetic vaginal surgery and procedures are growing by leaps and bounds because men and women are becoming more aware of their genital appearance. Female sexual dysfunction and incontinence are more spoken about today, spreading awareness and making people approach doctors more and more for their problems. Proliferation of sexually explicit material in digital print format and increasing prevalence of genital hair removal have made people sit up and notice. And undoubtedly, the advent of non-surgical methods and energy-based devices has taken the world by a storm and is finding a tremendous response and patient acceptance. I think as gynecologists, we really shy away from these problems. We know that a healthy lifestyle has never been more important. With COVID, everybody talks about a healthy lifestyle. However, we are talking only about correct diet, exercise, and sleep habits, which are drilled into the minds. A very important aspect of healthy lifestyle is sexual intimacy. And many studies show that couples who are happily intimate in longer ages have lesser chances of hypertension, cardiac problems, diabetes, depression, maybe even Alzheimer's. However, these issues are largely ignored by patients and physicians, and hence a demand for these procedures, though on an uptake, has been on a very slow rise. I think we are practicing aesthetic gynecology, it's been a decade, and now that the awareness is really spreading. Let's look at the Indian fast facts. 30% of divorces in India are due to unhappy couples. 72% of women are dissatisfied during sex. Nearly 22% of women in the OPD complain of incontinence, of which 73% is SUI, 16.8% is mixed, and 9.5% is urge. The Indian Journal of Urology 2013 paper says that nearly 40% of women above the age of 40 complain of incontinence, and we do believe that this is only the tip of the iceberg, and these numbers are really, really high. There is over a 120% increase in the Google search for vaginal procedures, And we know that pelvic organ prolapse is seen in nearly 41% of Indian population, and hence our burden is really, really high. The American Society reported a 30% increase in the rate of vaginal rejuvenation, and an Indian study done at our place shows the trends in aesthetic vaginal procedures rising from 4% to nearly 30% from 2012 to 2015. So let's talk about platelet-rich plasma. I think amongst the various forms of aesthetic gynecology, this is one procedure we can pick up and fairly, do it quite easily in our clinics. It's not a new concept, platelet-rich plasma. It was first described in 1970s. However, at that time, very large equipment was required. It was very expensive and large quantities of blood were required. In 1990s, the growth factors in PRP became a hot topic with a pivotal role in wound healing. And in 2000s, we've been using it in various fields, whether it's orthopedics, ophthalmology, gynecology, because we've had smaller machines, lesser blood harvest techniques, much better techniques, and FDA approval. A lot of people call it the elixir of life because PRP is rich in the growth factors. Before I talk about what are we, how do we make the PRP, how do we use it, let's discuss what are we using it for in gynecology. We are using it for stress urinary incontinence. We are using it for sexual wellness in terms of orgasm shot and the penile shots, for vaginal rejuvenation, for vulvar rejuvenation, for lichen sclerosis. We are using it in fat and filler fills. Along with them, we are adding PRP. We're talking about poor ovarian reserve and endometrial priming in IVF cases. So a little bit going back to our physiology, platelets are small disc-like colorless anuclear cells, and they contain proteins, cytokines, and other bioactive factors. When we know that the circulating platelets secrete the growth factors. So this is a coagulation cascade and how they help us with wound healing. Activated platelets release key growth factors involving in tissue regeneration. Basically, they have the alpha granules which release these growth factors. So these are the alpha granules releasing the various growth factors, which is what actually helps us using PRP in a clinical practice today. So what is the mechanism? These proteins and growth factors interact with present cells residing in the tissue, whether it's skin fibroblasts, endothelial cells, osteoblasts, depending on where we are using it. They bind to the cellular receptors and they activate intracellular events. These events mediate angiogenesis, new cell proliferation, migration of stem cells to the area, and basically production of extracellular matrix proteins. Dr. Mala also clearly defined in using radiofrequency for vaginal rejuvenation. We are looking again and again at the production of extracellular matrix proteins, which give us the strength. So what is PRP? It's an effective concentrate of multiple fundamental growth factors by virtue of platelets alone, which are stored as alpha granules. Normal blood has 6% platelets. In a PRP, 94% is platelets. And it is a degranulation of these pre-packed growth factors in a platelet which occurs upon activation. So what is PRP and what is not PRP? Whenever we are talking about PRP, remember that we are looking at a platelet concentrate of more than 10 lakh platelets per microliter. So this is in about a 5 ml volume of plasma. And this is the working definition of PRP. Lesser concentrations cannot be relied upon, and greater concentrations have not yet shown to further enhance wound healing. So we know that normal platelet count is between 1.5 to 3.5 lakhs per microliter. Here we are looking at 10 lakhs per microliter, and that is PRP. So it is concentrated by 4 times or above, and this acts as a catalyst for the healing process. So this is the double spin method by how we make the PRP. And as you can see, I have a video on this, but you can see very, very clearly that the RBCs have settled down. We have the platelets in the center, which is a buffy coat. And we have the plasma above, which is called the PPP or the platelet poor plasma, which also today can be used along with PRP, and it is really effective. So as you see, all the growth factors are highly concentrated in PRP. And PRP not only provides a bioscaffold, but also concentrated growth factors. The therapeutic goal of any PRP used anywhere in the body is to accelerate wound healing and cause matrix remodeling. So how do we prepare it? Well, there are various methods. We do a phlebotomy and draw between 10 ml to 60 ml of blood from the patient. There are 2 FDA approved methods for preparation, single spin and double spin. Both the processes involve collection of the whole blood, which is anticoagulated with citrate dextrose before undergoing centrifuge to separate the PRP. So there are various extraction systems. I'm not going into the detail of that, but we should get an extraction system which gives us at least 10 lakhs per microliter in a 5 ml volume. And ideally, we should use a double spin method, and that is what most of the experts believe. And the system should be such that it should be totally technician independent, and it should be totally a closed system so we do not infect it. Usually the anticoagulant used is ACDA, which is preferred for by using 10% CaCl2. However, the activation, today there are various methods by which we do not need to do activation of PRP. So I'll get on to that. So remember one thing, whenever we are injecting PRP, it's important that the microtrauma caused by the injection itself also stimulates the influx of macrophages. Once the platelets die, because the average lifespan of a platelet is 7 to 10 days, the macrophages continue the wound healing regulation by secreting the same growth factors. And amount of initial platelets present in the area determines the wound healing and explains why PRP speeds up the recovery. So this is a video in our lab of how we prepare PRP. Because of lack of time, I'm just going to go a little faster on it. As you can see, the blood is collected and it is mixed very well with the anticoagulant. Once it is mixed, here he is removing air, and I'll just show you how it is injected into the tube. So this is the PRP tube wherein we do a double spin method for collection. So once the blood is in, this is a smaller machine. It's a newer one which is available, quite affordable. Remember, we always have to balance both the tubes, and that is how we do PRP. The PRP is spun in this 2 times. The first spin is called the hard spin, which separates the RBCs. And the second is called the soft spin. After spinning, the first spin, this is after first spinning, there is a lock so that you make sure that the things remain segregated. And then we do the second spin. This is the PRP ready after second spin. And I'll just show you how, here it is being removed for usage. So these are ready-made tubes that are available. There's one from Region Lab. There are many labs now giving ready-made tubes. In this, the advantage is that you do not have to use anything. You just have to collect about 10 ml of blood, and then we have to do the centrifuge, and that is it. You do not need to collect large volumes, and they already have everything that is required. So basically, it is activated platelet state which releases the growth factors, and that is what we are looking at. The PRP can be mixed, it can be layered, it can be sprayed on, applied on top, or used as a biologic membrane. Okay, so this is how we are using PRP in various ways. Once develop, the PRP is stable and sterile in the anticoagulated state for 8 hours, but you should use it as soon as possible because the growth factors, the half-life is really small. Remember, there are contraindications to the use of PRP, bleeding disorders, oral anticoagulant, antiplatelet drugs, pregnancy, infection, tumors, cancer, chemo. One thing we must remember in our country is malaria and dengue. Any patient in the fever in the last 6 weeks, please do not do a PRP. Check their platelets before doing it because that can really be, not useful if you're trying to create PRP from very low platelets. PRP has a low risk and few side effects. This is a study which said that it does not stimulate any tumor processes, which was a concern earlier. So its application aesthetics, I think the commonest application is for alopecia androgenic areata. However, we are using it, for various problems in aesthetics, the commonest being urinary incontinence. We do believe today that almost 60% of women experience urinary incontinence post-childbearing, and it greatly affects a woman's lifestyle and confidence. In the West, it's one of the top reasons why elderly women are placed in nursing homes, and we know about stress and urge. What are the common treatment available today? We know that we talk to the patient about dietary changes, Kegels exercises, bladder retraining, medications and lifestyle changes. Weight loss is important. We talk about energy-based devices today. Dr. Mala showed it very, very well how it helps. And we have the HiFem chair today, which can really help with incontinence. Invasive procedures are birches, vaginal slings, mesh placements, which are now not in vogue, and artificial sphincters. When we come to sexual dysfunction, we know that 40% of women suffer from sexual dysfunction, 25% never orgasm, 46% complain of pain. And once we ruled out the hormonal, medical conditions, trauma, injury, and psychological, sexual dysfunction still remains very, very important part which we can correct today. So we, again, what are the current treatments? We promote healthy lifestyle, do sex education and counseling, adjustment of medications that have sexual side effects, hormone therapy, pain management, again, energy-based devices and HiFem chair help for sexual dysfunction. But we are using PRP as a combination for incontinence and sexual wellness. It is a one-step technique which has multiple applications. The O shot or the orgasm shot is a trademark term by Dr. Charles Runnell, so we cannot use it. So I like to call it the clitoro-urethro-vaginal complex augmentation, which is what we do with PRP for our patients who have female sexual dysfunction and urinary incontinence. O spot is the most distal space between the urethra and the vaginal wall. It is a one location for injection. The advantage of PRP compared to any filler like we do for G-spot augmentation is it is aqueous, it easily flows through the small bore needles, and it is evenly distributed, and hence you do not need to have a very meticulous placement of the needle. If you give one shot, it goes to the entire area. So how do we do the procedure? Topical anesthesia is given on the vulva and the clitoris. We withdraw the blood and process we can activate it. What we do is inject 4 ml into the vaginal wall and 1 ml into the clitoral corpus. We can use method described by Dr. Charles. So this is an injection into the clitoris, and it looks very, very, scary, but the patient usually tolerate this technique very well and they don't complain, and they come back for the O shots after 1.5 to 2 years. So what are the results of the O shot? Sexual distress scale revised shows that 70% of women progress from distress to non-distress and scores improved by 10 points. And the FFI statistics also improvement in desire, arousal, orgasm, and lubrication. There are many modifications of the O-shot method. We can do a clitoral injection on both sides, put more PRP in the clitoris, divide the vagina into multiple sites, and we can put PRP in trigger points on the pelvic floor, episiotomy sites, etc. But all these are modifications used for the different things. This was the paper by Dr. Charles Runnels on O-spot enhancement, which is undoubtedly very, very interesting. Well, we've not seen so many side effects, maybe bruising, hypersexuality, mild dysuria, but nothing in reality. We can always optimize the results of the O-shot by Kegel's exercises, healthy diet, and hormone optimization with bioidentical hormones like Dr. Red spoke about. That's really, really interesting. So it really helps us in wellness. And today we are combining PRP with energy-based devices. At my own place, we have a radio frequency device. I have the Thermiva, which Dr. Red promotes. And I think a combination also really, really works well. However, if we are using it with a CO2 fractionated laser, the advantage is that you don't need to inject the PRP. The fractionated laser creates microscopic treatment zones, and PRP can be layered on it. So we can do without the injectable part of it. We are using PRP for penile dysfunction and enhancement. It is called the penile shot or the P shot. Again, this can be combined with an energy-based device. This is a fairly common condition in, more common in postmenopausal women, but we are seeing it in midlife today, like lichen sclerosis. We know that they develop white spots on the vulva. Over time, they become larger. They get aggregated white plaques and they ruin the architecture of the female external genitalia. The current treatment is only steroids. Beyond a point, steroid may stop acting, and that is the time we usually use PRP along with energy-based devices sometimes. 2 injections of PRP 6 weeks apart is what we use at our clinic, and we have very good results. Of course, we must do a biopsy and confirm lichen sclerosis before we go ahead with this. We are using PRP for vulvar skin at our clinic when there's a lot of patients complain of dryness. I'll just show you the picture of this 42-year-old who came to our clinic crying with severe dryness, could not take her hands off. This is an immediate sitting of PRP and look at the difference in her skin. She really did well. We are using fillers for labia majora augmentation. So we are using fat and we are using fillers. And today we can add PRP in the fat fills, and this really improves the graft uptake. It increases the survival and longevity of the graft. So this is one of our patients for whom we've done a vaginal tightening labiaplasty with fat filling, and we have added PRP, and this is what it looks like at the end. So we can use, derm electroporation. So if you do radio frequency followed by derm electroporation with PRP, this is called needleless O-shot, and this is currently being tried for better urinary control and orgasmic dysfunction. I think whenever you don't inject a patient, the patient is so much happier. Derm electroporation opens up the channels, lets the PRP enter inside without us injecting anything inside. What are the newer things in PRP? We have PRF, which is called platelet-rich fibrin. It's a second-generation platelet concentrate with a 3D architecture. Here we have to do an anticoagulant-free blood harvest. No exogenous compounds like thrombin or calcium need to be added. And this is available in the injectable form. Of course, we need much better studies and larger trials before we can put anything down. And I find PRP a very useful tool in my practice. Patient acceptance is really easy. And thank you very much for having me here again.
That was a wonderful talk on PRP. We got a comprehensive idea about what is PRP is all about. And I request our president and coordinators of this session to give concluding remarks.
I think, Madam, can I proceed with vote of thanks?
Yeah.
Yeah.
Thank you, Dr. Sejal. It was wonderful. Sorry, Sejal, it was wonderful talk. Thank you so much.
Yeah.
Thank you so much.
Deepa, 1 minute. I should congratulate Dr. Mala for arranging such a wonderful workshop. All the speakers did very well. We learned a lot of things today. Though we know a little bit, now we know, in depth certain few things. It was very useful workshop. Thank you once again. Thank you. Deepa?
Thank you, ma'am. It's my privilege to deliver vote of thanks in this CMS pre-Congress Cosmesis workshop. I start with my gratitude and thanks to the organizers, Dr. Hepzibah Madam, the President CMS, and Dr. Malaraj, the founder IAGE TNL Tamil Nadu chapter, founder president, and Dr. Shanti Gunasingh, Vice President, Chennai Menopause Society, for wonderfully organizing this workshop with practically relevant topics. And I can understand the very hard work behind selecting the speakers and organizing. And Dr. Mala, especially a very thankful and wonderful workshop. And extend my thanks to the chairpersons, Dr. Samari, Dr. Premlata Madam, Dr. Shanti Gunasingh, Dr. Dhanlakshmi Madam, for chairing the sessions very lively and their expert and valuable opinions. I must mention my deep sense of gratitude and big thank you to our international faculty, Red Allinson from USA, for his time and sharing his knowledge in educating us. His talk on testosterone pellet is excellent, and it is a boon for women in midlife. I wish to express my gratitude to all our national speakers, Dr. Annie, Dr. Yashwant, Dr. Vaishali, Dr. Senthil, Dr. Ragini Agarwal, Dr. Snat, and Dr. Sejal for their excellent talk and many practical points in their talks. I must thank Padma, our treasurer, and Geeta, our executive committee member, for the excellent coordination of this whole afternoon sessions. A big thank you for Shield Healthcare for giving us this platform and supporting behind the screen. And finally, thanks to the tech team who ran the show without any glitches. And I have to thank all the delegates who was patiently listening and encourage the speakers. With this, I end my vote of thanks and see you all again tomorrow for a grand inauguration of our Central Chennai Menopause Society conference and mind-blowing scientific sessions tomorrow. See you again all tomorrow. Thank you, ma'am.
Thank you.
Can we log in? Yeah.